Both in diabetic macular edema and AMD is almost the same, like it is VEGF-driven prostaglandin inflammatory. So why is that the number of injections we need to treat AMD is always quite more? Like in DME, it keeps on reducing in the second year, but we don't see that in cases of AMD. So why is that the fluid is more resistant to treatment when we compare it to DME?
So, very interesting question. Again, bottles down to the same, that where the pathology is. So, as you rightly said, marker is same, cytokine is same, VEGF driven. But if you see CNVM pathology is at choroid, deep. Diabetic macular edema pathology is at the inner retinal level. So inner retinal level intravitreal drugs are easy to compensate that. But it is difficult for drugs to penetrate deep down in the choroid. So anything which goes below RPE, that's, for drugs is difficult to penetrate. That's the reason brolucizumab came. So brolucizumab had better penetration in these, in these situations, but unfortunately that was associated with some of the adverse events. Otherwise, it was drying these patients much, much better. That's the reason that with the traditional anti-VEGF molecules, you need more in numbers because the pathology is deep. That is the reason that, if you look at type 3 MNV, it responds in very less number of injections because pathology is in the inner retina.
But then when we see brolucizumab, the effect on diabetic macular edema is not that, it's not that wow effect.
It's not the wow.
And it takes longer for the fluid to actually reduce in cases of diabetic macular edema. Rather, the PD regresses much faster with the brolucizumab than a DME.
Yeah, that's absolutely. So the thing is, if you look at DME, means even if the protocol T or whatever protocols you see, these patients never get dries up and their visual acuity is, stagnant at some place. So it has more of a neurodegeneration at the drill level. The disorganization which happens at the level of inner retina. So it means we can just hypothesize at this point is because it's a multi-organ disease and it has some kind of neurodegeneration disease. However, in AMD you see only place where you disturb this neuronal connection is the photoreceptor. Nowhere else. This entire retina is good. But here the entire retina neural connection is disturbed because of the overall impact of the disease. So entire retina is affected there. Here there is a sector is affected. So that's how we can hypothesize.
So is there any role in myopic CNVM or MNB? Is it different from this? Myopic
CNVM actually, because I think I will definitely give 1 point to postgraduates. Always remember myopic CNVM is a disease of complaints. Do not believe on OCT on myopic CNVM. OCT you will feel a very, very subtle change. But patient will say, sir, since 2 days my vision, central vision is distorted. You believe on patient and inject him. Do not believe on OCT. Because what happens, all these myopic CNVM, their entire posterior pole is already distorted. So you do not see those real changes what you see in a normal retina. So this is, studies have also proven, shrimp means subretinal hyperreflective material. That's what we call it. If you see mildest of shrimp in myopic CNVM, injected based on the patient's complaint. If patient complains, 100% you inject it. The only difference that you need to make is that whether it's a real myopic CNVM or with just a, Fuchs spot. That differentiation you can do very easily with the help of OCT. You scroll your OCT on a 3D. If you see there is a breach at the RPE, that means you are dealing with a myopic CNVM. If there is no breach in RPE, just the hyperreflective material with a shadowing, that means you are dealing with a Fuchs spot. And as sir asked, to be specific, myopic CNVMs responds beautifully even with 1 or 2 injections, and you do not require many injections in them.
Introduction. He is the real master stroke player of Bihar Ophthalmology, and as such, per Dr. Sunil Singh sir, he has a tagline since has done many things first in Bihar. So he has a tagline of first in Bihar. So he's famous for that. And I'd like to invite Dr. Rajesh Tiwari sir on this dais.
Thank you, Physical Society, for giving me this opportunity. After this thoughtful presentation by Dr. Ashish Sharma, now my time to present on this topic, that is IOL explantation. Uh, just a minute. IOL explantation, I would say that it's much more difficult than to implant the lens. So there are certain situations where you really need to take out the lens which has been implanted. And one of the common indications nowadays is the refractive surprise, because many patients, they want to have 6 by 6 vision. So the patient expectation has increased, and so the surgeon. So any surprise needs IOL explantation and exchange of the IOL. Second is the IOL opacification. Nowadays, we can see some of the patients coming with the IOL opacification. If the IOL is causing recurrent inflammation or glaucoma, if the multifocal or trifocal lenses do complain of lot of dysphotopsia, not able to tolerate, or if the patient has gross decentrations, which is due to inadequate support, in this situation, you really need to take a call and remove the lens. Since it's a definitely difficult procedure, so you need to take precautions, because it is going to cause some collateral damages, like you have to sometimes enlarge the incision. That would cause change in the astigmatism. You have to protect the endothelium, so don't hesitate to use lot of copious good elastic, viscoelastic, and you have to protect the posterior capsule so that you have adequate support to go ahead with the implantation also. So you need to have special care when to remove these IOLs. It's sooner the better, because once there is adhesion, it will be difficult. So this was a case of refractive surprise. So 2 weeks later, the patient refraction came out to be unexpected level. So what I did is that I wanted to exchange the lens. Here I am injecting viscoelastic below the IOL optic, inflating the bag, and trying to remove the haptic of the lens into the anterior chamber above the anterior capsule. You have to do it carefully, do some rocking movement, but since it was a just 2 weeks old case, so it was not very difficult. And to protect the posterior capsule, you have to be very much careful. For that, what I do, I always do that, I try to implant the lens before I take out the lens. This is called IOL scaffolding for removing the IOL, so that it protects the posterior capsule, and there is no touch of any vanas or any surgical instrument while cutting the lens. So I am implanting the foldable lens through the 2.8 millimeter incision, and after implanting in the bag, I will just hold the haptic of the lens, and I will take it out through the main wound, 2.8. There is no need to enlarge the wound. Earlier days, I used to cut the lens through and through to take it out, but nowadays, you can just make some, do some pie cutting and then you remove. I just injected Viscor, no financial interest, just to protect the endothelium. This is Osser cutter, but Osser cutter is little stout, so you can use other, even Manas can do the work, and there are some other modifications also. So I'm just cutting about less than 1/2 of the diameter of the lens with this one, and then trying to hold the haptic with the other instrument. I am cutting on the other side just to take small pie of the lens optics, and that is sufficient most of the time if the lens is very much pliable. So I will roll out the lens gradually and slide out through the same wound. Again, you have to protect the endothelium. Don't hesitate to put a lot of viscoelastic, and always keep the chamber formed. And I'm just rolling out the lens through the 2.8 millimeter incision, and it can come out without distorting the wound or without damaging the endothelium or posterior capsule. So this was one case. Coming to the another case, where even not taking out any pie would sometimes help to take out the lens. This is another case. What I am doing, that I am going more than 1/2 of the diameter of the optic, and not necessary to make a pie, or not necessary to completely cut it, go beyond 2/3 of the diameter. Here it was a case of amputated IOL, so I just made a nick there and then rotated out the lens through the same 2.8 wood, so 2.8 millimeter incision. So there is no need to, again, to completely cut it, or no need to enlarge the incision. And not to say that I use the IOL scaffolding here also. This was a dark-skinned person, and that was the only white thing I could see in his body, the white lens. This patient had actually undergone phagosurgery for getting freedom from the light. But he landed up after 2-3 years with this much of opacity, And so I had no choice but to remove the lens. This was a Renner kind of lens. So here again, since it was too old, 2 to 3 years old, I gently tried to remove all the adhesions, all the capsular and lens haptic junction with multiple maneuver, injecting viscoelastic again and again, and trying to be very gentle, and then it was taken out from the bag. This is, since the lens became little steep, so I thought that I had to cut it through and through, and just holding the haptic of the lens, I cut it through and through, and then took it out. See, this was a Freedom, actually hydrophilic lens, implanted 3 years back, and we get a lot of these type of lenses. So here I implanted 3-piece lens in the sulcus. As I was not very much sure of the capsular bag, so I implanted in the, this is very peculiar type of case, just like zonular cataract with black opacity in the central lens, and all rest of the part was clear. In the pupillary area only it got opacified, and the adhesion was so strong that I actually could not negotiate through the iris spatula, so I had to use a 26 gauge needle from 2 side port to make any gap between the anterior capsule and the optic of the lens. And after several attempts, I actually created some space, then injected viscoelastic that went behind the posterior part of the lens, between the posterior capsule and the optic, and then gradually I tried to disengage the haptic, but I was not successful. So what I did was that I left the haptic in the place, and I cut the lens between the optic and haptic. So that is the way one can go ahead when you are not able to completely separate the lens, so that you don't injure the capsular bag or any remnant of the capsule. Here, repeated maneuver actually caused some posterior capsule rent, but that was managed very well. So I'm cutting the optic haptic junction, leaving behind the haptic of the lens. That doesn't cause any problem. So I left it and then implanted this multi-piece lens in the sulcus, after taking care of any vitreous in the anterior chamber. Since it was round, there was no haptic to hold upon, so I completely cut the lens and then removed it through the same 2.8 millimeter wound. And then I did the anterior vitrectomy. But still the capsular support was sufficient enough to have a multi-piece lens in the sulcus. So the wound was salvaged. It was possible to implant the foldable lens in the place, and patient had a good outcome. Never to forget to do the triamcinolone assisted anterior-vitrectomy. So thank you very much for patient hearing.
And the presentation.
Just one observation about cutting the lens either with a Vaners or a lens cutter. If you have a Coughlin hook or a lens dialer, you can support and push it between the arms of the Vaners, and that pushing from the 6 o'clock position or the distant position, that ensures a stability of the lens, and then you can cut it easily. Because this is what
that I did in the
last case.
Yeah.
What you did in last case, one can do it on all cases basically.
Yeah,
so that facility.
If you have haptic to hold it, it's very easier to hold the haptic.
The most common is a broken haptic, in which you have to cut. In
you
that case, if you do not have a support,
you have to
I
do
mean, this
that.
is a very good technique. Yeah,
You need to have counter traction.
yeah, counter traction.
Now our next talk is by Dr. Pranita Sahai. She is the daughter of the soil and proud father, Dr. Prananranjan sir. She has done her MD from AIMS, FRCS Opt, FRCS and FICO, and FICO in refractive surgery. She is the associate consultant presently working in the Department of Cornea, Cataract and Refractive Surgery at Center for Sight, New Delhi. And she was the ex-assistant professor at Lady Hardinge Medical College, New Delhi, and ex-assistant professor at University College of Medical Sciences, New Delhi. She has 87 publications in Index Journal in PubMed to her credit, and she has authored 26 books chapter at such an early age. She is the recipient of Best Scientific Award in Keracon 2018 and ICS KRS 2019, and she is presently the convener of AIS and SSTC in 2023 at Kochi. So, on to Pranita.
Ophthalmic Society for giving me this opportunity to get back to my own roots. So I hope I'm able to live up to the expectations, and thank you, Dr. Sujit, for the invite. I'll be presenting on the topic challenging surgical cases in cornea. So any patient who comes up for keratoplasty does not come with only a corneal opacity or a decompensation. He has a lot of other associated problems that you need to deal with in the same surgery that you are planning for. The patient may have cataract, may have aphakia, the patient may be post-glaucoma surgery, the eye may be vitrectomized, there may be associated retinal detachment, or it may be a case of severe graft infection. So after that, you have crossed the first barrier, that is lack of donor cornea availability. The second major barrier is to tackle these associated complications in your surgery. So dealing with the first situation, keratoplasty in aphakia, the associated risk in these patients is obviously an increased risk of suprachoroidal hemorrhage, globe collapse, and vitreous loss because the lens is not present in these patients. So other than proper IOP control preoperatively that you routinely do in all cases, use of flaring ring intraoperatively can also avoid a globe collapse. And to manage the aphakia, you can do a scleral fixated IOLs in these cases. ACIL is not my first preference because obviously it causes a greater endothelial loss in the long run and increased risk of graft failure. So this is a surgical video where we'll see penetrating keratoplasty with scleral fixated IOL in a case of corneal decompensation with scarring with aphakia. So as a routine procedure that we do for SFIL, a localized peritomy at 3 and 9 o'clock position, creation of a 3 into 3 millimeter scleral flaps on either side is being done, and a sclerostomy incision is being made, this being a blind procedure here because you cannot see the entry in the sulcus because the cornea is all opaque. After the sclerotomy is being made, a partial thickness incision is being made with your trephine, and when you cut through, now this is the most risky part, that is you have to pull the three-piece IOL in an open globe position. So you will use the normal crocodile forceps, pass through the sclerotomy and pull the haptics out. Once both the haptics are out, you can breathe and now tuck in both the haptics in the groove that you have created. After this, the procedure is normal and simple as routine keratoplasty. All the suturing is done and the peritomy and the scleral flaps can be closed. The second situation is if you have a patient of corneal opacity with retinal detachment. Often these patients are ignored and are denied surgery at most of the places because a combined procedure, keratoplasty and RD management, is often not available at most of the places. The challenge first is whether to plan a combined surgery or do a stage procedure in these. A combined surgery is always better because in stage surgery, either you are delaying the RD surgery or your graft will get decompensated when the second surgery is done. So a combined surgery can be preferred. In these situations, a temporary keratoprosthesis can often be helpful. The Oro-K Pro provides a temporary keratoprosthesis which is not too expensive, comes in just 2,000 rupees, and that can be useful in these situations. Also, it is important to assess the visual potential in these patients preoperatively because the potential obviously is poor in these patients. If the other eye is normal, the surgery should usually be avoided because you will never be able to match the expectations of the patient. Now, this is a patient who was a 12-year-old male with brittle cornea syndrome. The other eye had a failed graft, was enthesis, and the right eye had a failed graft. The patient had previously been operated outside, developed a failed graft, was aphakic, and the ultrasound suggested RD. The flash VP suggested some good visual potential. Hence, we planned for a temporary keratoprosthesis assisted VR surgery and PKP. Initially, a lamellar dissection of the cornea was done, and the last layer of host cornea was left behind to avoid an open globe time so as to reduce the risk of expulsive. After this, the temporary K-Pro, this is the Oro K-Pro with 6 holes which was sutured on the host bed with a 7-0 vicral suture. Following this, the retina surgeons took over and they created 3 ports at 3 millimeter position, and the RD could be then the last layer of the membrane which we left behind was removed with a cutter. The RD could be visualized and then PFCL assisted settling down of the retina was done. The breaks were lasered. The ILM was then stained with BBG dye, and an ILM peeling could also be done. You can see the clarity through the K-Pro is really very good. Even the clarity for a retina surgeon was good enough that they could do an ILM peeling procedure through the K-Pro. The visualization of the periphery was also very good, wherein the laser of the periphery could also be completed through this keratoprosthesis. Since the child was also aphakic and we had to put in silicone oil, so to keep the silicone oil away from the graft, it was important that we put in silicone oil retention sutures, which was done with 9-0-proline. With the help of a handshake technique, a 30-gauge needle and a 9-0-proline, a crisscross mesh was created so that the silicone oil that was later injected could stay back behind. Now the silicone oil injection is being done. 2 ports were closed, but the pars plana, the infusion port was still left behind. Now was the bigger challenge to remove this K-Pro and put in the graft, because the silicone oil would start extruding as soon as you remove the K-Pro. And in the presence, we had injected the 5000 centistoke oil, which is very viscous. Graft suturing is also difficult, so continuous flushing of the surface by the assistant was necessary. After the 4 sutures were put in, an air hose bubble was injected, and we could push back the silicone oil in place. After the suturing was complete, silicone oil augmentation was done, and then the port was closed. Also, a temporary tarsorrhaphy was done because limbal stem cell deficiency was there. A poor healing was expected. This is the day 10 picture, a graft clarity of 4+, and the anterior chamber was well formed. There was no silicone oil in the anterior chamber. Although the vision that the child gained was just 3/60, but in a nunite patient where the other eye is thiazical, even that gives a fair amount of ambulatory vision to the patient. Moving on to the next situation is therapeutic keratoplasty. Normal situations where you're managing corneal infection, it is relatively easy, but when you're doing surgeries for graft infection, it is often difficult because the infection in graft infections progress rapidly. Sometimes even the host cornea is involved. You need to take a large size graft. You may have an associated end of all that needs to be dealt with in the same surgery. So always and always, an early intervention gives good outcomes. Aggressive surgery, managing all sites of infection in the same sitting is important, and sending samples for culture and tracking back your donor corneas in the previous surgery is obviously important. Now this is a patient, this is day 1 post-DSEC. It is an unsightly image to see that this is day 1 post-DSEC. Patient developed a pseudomonas infection, near total corneal infection. So a very large size, nearly the entire cornea was trephined and removed. And you can see after this, the partial thickness trephination, the host and both the donor is being removed. The donor lenticule and the host cornea both were sent separately for culture sensitivities. The peripheral, in such large graft suturing is often difficult. Hence, you can create a ledge with the help of a crescent in the host rim, so the suturing is easy. Large grafts, always PI is essential, which was done. Following this, the suturing was completed in a routine fashion. This patient was a post-trap patient and also had an associated bleb infection, was showing a whitish discharge in the area of bleb. Hence, the bleb area was also explored, necrotic tissues removed, and the conjunctiva was then advanced and sutured. End-off was also present, and hence an intravitreal antibiotic injection, polymyxin B and vancomycin were given. Moving on to the next situation is PK triple in operated traps. Glaucoma is one of the most common complications that patients for whom you're doing a keratoplasty comes up with. Sometimes they are post-trap, sometimes post-AGV. Challenges in presence of patients who have operated trap is you may damage the bleb intraoperatively. So preserving the bleb during your trephination and suturing is all very essential. Now, this is a patient in which optical triple was done post-trap. You can see there is a thin cystic bleb in the supranasal area, and there's a blackish hue also coming, showing that the bleb is very thin. A 3 millimeter mark was made around the area of bleb so that any inadvertent suturing or damage to the site of the bleb can be avoided. And eccentric trephination was then done so that the bleb can again be preserved. So don't do a central trephination, and eccentric trephination can help in preserving the bleb. So after the host cornea was trephined and cut out, we can see there is a white cataract, non-dilating pupil, presence of synechiae, Hence, local focal sphincterotomies were done to dilate the pupil, following which trypan blue staining and a rhexis can be done. Either you can do a capsulotomy or a rhexis followed by radial nicks to expand, to give expansion in this rhexis, and then deliver the nucleus with the help of 2 instruments, followed by a quick IA of the residual cortical matter and placement of a 3-piece IOL in the sulcus, and then closing the eye with the graft and interrupted sutures. Again, during suturing, it is important that you may even, unlike normal routine keratoplasty where you do equal size sutures all side, you can have a differential length of suture near the site of bleb to avoid damage. In the end, to check a leak is always very essential to check for any leak at the site of the bleb. Moving on to the next situation, a patient which is an eye which is vitrectomized and has an AGV. In such situation, to avoid the globe collapse, you can even use a pars plana port and infusion to maintain the globe integrity when you're suturing. So here you can see the pars plana infusion port has been made, and also a Fleringa ring which can be sutured to avoid the globe collapse immediately when you open up, because the eye is vitrectomized, fluid filled. As soon as you trepine and open, all the fluid is going to come out and the globe can collapse. So here, after the partial thickness trephination, a side port entry is made and you give time for the eye to decompress, and you egress out some fluid from the anterior chamber so that a sudden hypotony is not created. After this, you can see there is an IOL and the AGV tube is present behind the IOL. There was a focal area of iris defect superiorly which was closed with pupilloplasty suture, which was again done with 10-0 suture. There's no need for proline, even a 10-0 suture does well. And just a gentle traction, you don't need to pull the iris too much because the iris is always atrophic. Just a gentle traction and apposition is enough. After this, the infusion port all this time was closed because you don't want pressure to be building up from behind. Your IOL can extrude. But definitely during the time of suturing, after 4 sutures are there, you can start the infusion to build up the pressure so that your suturing strength is adequate and you do not have loose or tight sutures. At the end, the infusion port can be removed, and essentially it was sutured because there was leak from the side of the port. So the next most important thing is, when you don't have donor corneas, what to do in such situations. So this was a case of keratomalacia sequelae, corneal melt, AC flat, a 5-month-old kid, and it was during the first wave of COVID. We did not have donor corneas, fresh donor corneas, and hence in this patient we used a glycerine preserved cornea. The graft is looking very ugly, and you definitely don't want to use this in a pediatric keratoplasty. But obviously, the most important thing is to maintain the tectonic integrity of the eye. That's the primary target, and that is what we did. And pediatric keratoplasty, as you know, the cornea is very soft and malleable. It does buckle, as you can see in the superior aspect, it was buckling. And the glycerine cornea is very stiff. To match them is difficult. We were expecting that the epithelium may not heal, the graft may not take up, but this is the 6-month picture. The graft did take up well, got epithelialized, and we could subsequently plan the patient for an optical keratoplasty in the second sitting. Now, if you don't even have a glycerine cornea, as we already had a nice presentation on Tenen patch, that is also one of the good rescue measures which you can do in at least small corneal perforation. So this is the small surgical video in which we can see in the supratemporal aspect a small peritomy is being done, and from which the Tenen graft tissue is being harvested. Always try and oversize your Tenen graft by 10 to 20% compared to the size of the defect that you have. And if you take this graft from the supratemporal aspect, just a mechanical apposition of the site of harvest is more than enough. You don't need to use glue or suture, it just gets apposed. This was a case of peripheral corneal perforation, hence we injected air pylo, reposited the iris tissue because it was a fresh perforation. Patient had a history of just 24 hours, so we didn't excise but reposited the iris. And subsequently, we also excised surrounding area of the conjunctiva so as to make the suturing easy. And the patient had previous history of flectnular keratoconjunctivitis. Predominantly, this looked like a case of PUK and sterile melt. So we did a localized conjunctival resection, following which the Tenen graft was placed here and sutured with interrupted sutures, and the sutures were then buried and surgery was completed. This is the 3-month follow-up pictures. You can see the graft did take up well. got opacified. And although there was a focal adhesion of the iris there was no inflammation or iritis that the patient had, and the ASOCT shows that the graft got well integrated with the host cornea. So just to conclude that every problem has a solution, and it may sometimes just be another perspective that we need. Every case in cornea is different, and not one technique may suit all, so meticulous planning is essential for all cases. Thank you.
You showed variety of cases. I would just like to ask you for the first case where you had done a blind side port entry for the scleral fixated IUL. Could that have been done after taking out the donor button, or what difficulties do you face during that time, because there could have been a cataract earlier also?
Yes, sir. So first, we could not have done the SFIL before because the clarity was not good. To do a second stage SFIL, to take the patient, there are two main concerns. One, you need to do two-stage procedure. The patient has to be taken to the OT for a second procedure. And second, that the risk of corneal endothelial loss of the graft tissue loss, the graft endothelial loss, and the risk of graft failure increases. So if it is possible to do in the same sitting, why not do in the same sitting is...
But after removal of the donor button, then you make the entry. That was what I was asking. Does that make much of a difference?
To make the entry after the...
For the scleral tunnel which you did the entry,
Yes, sir.
you did prior to removal of the donor button.
Yes, sir.
So that was I was asking. You could have done that. Is there any difficulty which you face specifically?
Yes,
So
so
you do the
if
blind.
we cut out the host cornea, and in the open globe position, since there is hypotony, making an entry becomes very difficult. So there is another thing that we can do. We can debulk the cornea, the 80% of the depth, do a lamellar dissection so that you have some clarity of the anterior chamber, and then make an entry so that you
this is
are
what I
not
was
doing a
like.
blind procedure.
Hi, Dr. Pranita. Very nice situations and difficult cases, so well managed. In the same case, I just wanted to ask, pre-op lowering of IOP as we start mannitol.
Yeah.
So anything different you do to lower the IOP, because vitreous loss is like so much in open sky. Yeah.
Yes, so just one thing, other than mannitol and giving all anti-glaucoma that you can do, appropriate pinky that we do in all cases, you can also make a side port entry, decompress the anterior chamber for some time, for say 2-3 minutes, so that the aqueous egresses out, the pressure lowers down, so that when you trephine, that time your pressure is not going into sudden hypotony. You have already created a hypotony before opening up the cornea. So that is one thing that you can do.
Yeah, that's excellent tip. Another thing, just one. You prefer multi-piece IOL in triple procedure?
Ma'am, in all cases, we prefer multi-piece IOL, or not multi-piece, but you can even go for a PMMA lens.
Yeah, PMMA.
Yeah, but a multi-piece IOL sometimes is often easier to dial in because the PMMA is very rigid. You need to often sometimes manipulate the iris too much to tuck the second haptic, which becomes very difficult. A multi-piece IOL, the second haptic tucking is not very difficult because you can easily pull it in. It gets malleable. It's malleable. You can modify.
It makes easier.
Manipulate it easily.
Yeah, yeah. Thank you. Thank you.
Wonderful presentation. I mean, we are proud of you.
One and Ashirwad to you. And I am in habit of using abbreviations, but you were one upon me. Your abbreviation I could understand all but except one, that KRPRO in VRSXB with PKP. Can you decipher that? I couldn't understand that.
Keratoprosthesis
Keratoprosthesis
with vitreoretinal surgery.
with vitreoretinal surgery in
And penetrating keratoplasty.
and penetrating keratoplasty. So again I repeat, KRPRO, VRSXB in PKP. Yes, thank you. It was a nice talk.
Nice observation, sir. Thank you, Dr. Pranita, for a wonderful talk. Guest speaker, Dr. G. Sithapati, and he is the renowned and senior ophthalmic plastic orbital surgeon, living and currently working in India. He presently heads the eye department of Manipal Hospital, Salem, Tamil Nadu. He has completed his MS in India and obtained MRCS, FRCS, and FRCO. And he has done dual subspecialty fellowship in the branch of oculoplasty, orbital surgery, and ocular oncology and neuro-ophthalmology. His area of special interest includes the treatment of thyroid eye disease, complex orbital trauma, and treatment of orbital and adnexal tumor, apart from eyelid and lacrimal surgery. Research interest includes use of integrated implants for eyelid and orbital reconstructive surgery. He has many publications to his credit and has been a regular speaker at national and international forum. So on to his talk on ocular surface tumor.
And thank you very much for the warm words of introduction. And many thanks to Patna Ophthalmic Association and my very dear senior colleague, respected senior colleague and good friend, Dr. Mishra, Dr. Sujit Kumar Mishra, for having given this wonderful opportunity to be here this morning. Now, just a brief overview of ocular surface tumors. Now, some of the topics can be so vast that every entity is probably would require a separate discussion. So I'm going to try and be as brief and also try to cover as much of it as possible. So first, with some relevant terminology. Now, the ocular surface functional unit, as we all know, it includes the ocular surface proper, that's the cornea and conjunctiva, and the adnexal mucosa and caruncle. And in addition to that, it also includes the meibomian and Zeiss glands, the lacrimal glands, and the lacrimal outflow system. However, we are going to stick to the tumors involving the ocular surface proper, that's the cornea conjunctiva, and the very near adjacent mucosa and the caruncle. Now, I just wanted to start off with a working differential diagnosis. Of course, we all know that we have standard classifications, especially the ones that we regularly follow as ocular oncologists, is the WHO classification. But I've just simplified it to have a working differential diagnosis of when and what to think when we see a surface lump on the ocular surface. So we have the congenital lesions like the dermoid, the lipodermoid, accessory lacrimal gland tissue, and vascular malformations, the arteriovenous malformations and the lymphovenous malformations. And then we have the acquired lesions, starting from the very benign pinguicula and pterygium, and granulomata, pyogenic granuloma following conjunctival trauma or surgery, and true granuloma, sometimes seen in sarcoidosis, and viral papillomas. Then we have the lymphoproliferative lesions, which have the full spectrum from benign reactive lymphoid hyperplasia to conjunctival lymphomas. And then we have the pigmented lesions, which also can be benign or malignant. And last but not least, the most important clinical entity of ocular surface squamous neoplasia. So we'll start with clinical entities and brief management outlines of those. One of the commonest lesions that we would encounter as a lump on the ocular surface is the HPV, or the human papilloma virus related conjunctival papilloma, which is nothing but a benign epithelial tumor of the conjunctiva. It could be sessile or pedunculated mass, and it has a strong association with the strain 6/11 of HPV virus. And the treatment is surgical excision with cryotherapy to the base to prevent recurrence. The next benign entity that we can sometimes be baffling or even alarming to the patient and to the clinician is the conjunctival lymphovenous malformation. Now, lymphovenous malformations can be isolated, or they can be the surface component of an orbital lymphovenous malformation. One has to distinguish this very commonly from a salmon patch or an arteriovenous malformation. Now, clinically, a salmon patch will actually have a solid raised area. There will be a reddish hue, which is also slightly elevated, and there is a solidity to the lesion. And it will not move when we try to move it with a cotton-tipped applicator under topical anesthesia, whereas an arteriovenous malformation will be both compressible and also to some extent reducible. And when we compress it, it blanches under pressure, and then when we release the pressure, it will fill up very immediately because of the arterial component to it. In contrast to this, a lymphovenous malformation, on the other hand, will not follow these rules, and it will just be very diffuse and ill-defined. So, and usually to prevent missing an orbital extension, we'll have to do a contrast CT or an MRI, and that's done for complete evaluation. And intralesional bleomycin is the treatment of choice. So this was a young lady who came with a lymphovenous malformation. That's the result that you see after 4 injections of intralesional bleomycin given 4 weeks apart, and you can see a near total resolution of the lesion. And other benign conditions include the limbal dermoid. Ocular surface dermoids can be of 4 types, 4 grades. One is the conjunctival lipodermoid that we see, and the next is the corneoconjunctival or limbal dermoid, and the third type is the complex epibulbar choristoma, and the type 4 is the osseous choristoma. Now, type 3 and type 4 are usually distinguished histopathologically, and this is just one such example of a limbal dermoid, pre and post excision. And excision of these lesions, usually we need to remember that the lamellar sclerectomy and the keratectomy need to be done, taking care not to rupture or perforate the globe at the limbus especially. And usually I cover the bed with an amniotic membrane graft, and that's the first day post-op picture that you see there with the AMG in situ. And this is another example of a complex epibulbar choristoma or a type 3 limbal dermoid, where you can see even skin growth on the surface lesion, and that's again after complete excision with an amniotic membrane graft, as seen on day 1 in the post-op. And the other benign lesions that can be baffling to the clinician are the lymphoproliferative diseases, which can affect the conjunctiva. Now, this was a young child who had a history of atopic eye disease, chronic atopic eye disease, and he had classical atopic asthma and atopic dermatitis as well. And he suddenly developed a large nodule on the plica. And the parents were quite concerned about it. And when we excised and sent for histopathology, we just found it to be a reactive lymphoid hyperplasia. And usually the prognosis for these lymphoid hyperplasias, especially when they are reactive, are usually good. In contrast to atypical lymphoid hyperplasia, which need further workup and follow-up. So that's the child again with a post-excision and after amniotic membrane grafting. And usually for ocular surface tumors, once I excise the lesion, I normally put AMG as a substrate because it also reduces local inflammation and prevents vascularization, and it also helps in good healing and in replacement of the conjunctival tissue without scarring and sequelae. And the next important entity that we want to discuss about is OSSN. OSSN is a wide spectrum of dysplastic alterations of squamous epithelium of the surface of the eye, that's the conjunctiva and cornea, ranging from precancerous lesions to invasive carcinoma, and it's abbreviated as ocular surface squamous neoplasia, as we all know. And clinicopathological correlation is very essential for missing this entity. The next few slides will go through the entire spectrum of ocular surface squamous neoplasia from the very early to very advanced conditions that we encounter as oculoplastic surgeons. Now, the risk factors for OSSN include an advancing age, male predominance, smoking, chronic ultraviolet exposure, genetic mutation in the p53 tumor suppressor gene, HIV-like viruses. Coexistence of multiple factors mentioned above will also increase the cumulative risk. So now coming on to investigating a patient with OSSN after we clinically examine them is impression cytology, one of the very easy to do tests at the bedside. It provides cytological evidence of dysplasia, and it's very useful in evaluating disease in staging and follow-up. It's not an adjunct or a substitute for excision biopsy. Usually we use a cellulose acetate paper or a nitrocellulose membrane, and alternatives can be a biopore membrane, or even direct transfer onto a cover slide. So it's just steps of impression cytology. That's the direct method that's being depicted there. And this technique, the left side, it just shows the different areas from where we do impression cytology when we want to assess the ocular surface, as from the near the limbus and all the quadrants of the eye, and also on the cornea directly. And this impression cytology does have its limitations, and I don't want to dwell too much on that now. There are other recent investigative modalities that actually offer much more in-depth understanding of ocular surface tumors. They include the anterior segment OCT, OCT angiography, the ultrasound biomicroscopy, and the in vivo confocal microscopy. Now, we come to certain clinical entities. Now, one of the earliest manifestations of an OSSN could be a conjunctival dysplasia, which clinically is usually a flat lesion with localized xerosis or localized dryness, and it is usually distinguished from a Bitot spots because it is acquired much later in life, and it may or may not be pigmented, and it's usually well localized, and predisposing factors could be even the presence of HIV, like in this patient, who was a seropositive patient who presented with this sort of a picture. And the other common entity, or a slightly more advanced entity, is an elevated plaque-like lesion that is seen at the limbus with microfeeder vessels like this lesion that we see here. This was a 40-year-old female with the suspicious limbal nodule that was progressive for about a year's duration. And her risk factors was she was a farmhand with chronic ultraviolet exposure, and she was also a tobacco user. And the lesion, when we clinically examined, was apparently fixed to the deeper tissues. And she also had an ipsilateral preauricular lymphadenopathy that suggested that probably the disease was quite advanced. Now, in these cases, the thoughts that would run in our mind is it a intraepithelial neoplasia, or is it a carcinoma in situ, or is it an invasive squamous cell carcinoma? So in these cases, we would need to do aggressive surgery, and complete excisional biopsy is done with lamellar sclerectomy and cryotherapy to the free margins with AMG application. And the histopathology in this case showed a carcinoma in situ with surgical margins were free. And we also did simultaneous lymph node sampling, and that just showed reactive lymphadenitis. And so we just followed her up subsequently. Now, just HP slide of conjunctival dysplasia. As we all know, ocular surface squamous neoplasia is something that the origin is from the conjunctival epithelium. So usually the stratified non-keratinized epithelium becomes keratotic, or it shows hyperkeratosis, and also acanthosis, or loss of polarity of the cells, as we see in this case. And that is very typical of conjunctival dysplasia. And when this is untreated, it progresses on to a carcinoma in situ, where the dysplasia progresses to the entire thickness of the epithelium with continued loss of polarity, and also starts demonstrating large pleomorphic nuclei, increased mitotic figures, and the pathology, however, is still confined to the conjunctival tissue. And the next advanced stage is the infiltrating squamous cell carcinoma, where this is a slide showing a moderately differentiated squamous cell carcinoma, and that is the epithelium that's seen. And we can see that the malignant cells have actually started crossing the epithelial barrier, and they have started invading the conjunctival substantia propria, and that is a sign of invasion. Now, other clinical presentations of no OSSN, just wanted to contrast it with a typical presentation. Commonly, we see them as in the interpalpebral region. The interpalpebral OSSN are more common than those seen at the fornix or on the tarsal conjunctiva, because they're usually less exposed to sunlight. And this is a typical papillomatous OSSN that we see here with feeder vessels. In contrast to this, this was an OSSN that was proven histopathologically, developing in a cystic pterygium. And this is another invasive squamous cell carcinoma that you can see here. And this is in contrast to a conjunctival melanoma. Now, a pigmented OSSN has to be distinguished from a melanotic or a melanomatous lesion. And one of the clinical distinguishing features is hemolacria. For some reason, especially a melanoma, which is very aggressive, and it starts invading the orbit much earlier, and also the ocular surface extensively, hemolacria can be one feature that can probably help to distinguish a melanoma from a pigmented OSSN. So these are just some different clinical presentations. And this is a pigmented OSSN that was, that's there on the left side, and that's the one after surgery. And the surgical steps we just mentioned previously. And what do we do as adjuvant therapy in localized disease is to consider topical chemotherapy. So topical chemotherapy, the choices we have are either mitomycin C or 5-fluorouracil or interferon A. And we also do serial follow-up photographs after clinical examination. And when the first report is of infiltrating squamous cell carcinoma, we also repeat biopsy after chemotherapy, and further extensive surgery is planned based on that. So any patient who has an OSSN, whom we have seen, has to be followed up if the disease is localized without any invasion to the deeper tissues and without any metastatic spread. Then the follow-up period is for at least 3 years before we discharge them into routine pool of patients. And any patient whom we have seen with more advanced disease and infiltrating squamous cell carcinoma, where we've done extensive surgery, we probably will have to follow them up lifelong. So this was another interesting case. So from moving from the ocular surface, we've come to more of the orbital surgeon's perspective. So this was a 90-year-old female who had a blind thusical eye since the last several years, and she presented with a painful swelling around the eye, which was progressive since the last 6 months. Clinical exam revealed a spontaneous globe rupture with a left orbitopalpebral mass. Initially, I was a little clueless about the diagnosis, and there was no clinical evidence of regional lymphadenopathy. Any orbital inflammatory mass, I normally look at the lymph nodes, I have a look at the nasal cavity and also the oral cavity, because it gives vital clues to what's going on in the orbits. And that was also inconclusive, and systemic workup was again normal, including bloods, ultrasound abdomen, screening x-rays, and everything was normal in this lady. So we went on to do an imaging, And that showed a fairly well-defined mass in the left orbit. And apparently that was encasing the already thicical shrunken globe. You can see that there. However, the paranasal sinuses were clear, which means there was no sinus pathology contributing to this. And the bones of the orbital walls were also intact. There was no bone erosion and bone destruction either. So because it was a blind eye and she had all these features and I wanted tissue diagnosis, I did an exenteration, and that was the gross exenterated specimen, and that's the reconstructed socket after cryotherapy to the apical soft tissue, and the socket healed quite well. And the histopathology was a moderately differentiated squamous cell carcinoma, and fortunately the margins were free in this exenterated specimen. In this case, I'm presenting only to help clinicians remember that an ocular surface squamous neoplasia can also occur in a thicical eye. So any symptomatic painful blind eye needs careful examination of the ocular surface too, and not to be ignored. This is another patient who had a neglected ocular surface squamous neoplasia. She presented with a large nodule that began its origin from the limbus, but it was invading and extending all the way to the inferior fornix. And she was a 60-year-old female, well-controlled diabetic, and she had neglected the lesion for almost a year, and it had progressed to the presenting status, and she had an inability to close the eye fully with vertical ocular movement limitation and constant irritation and discomfort for 3 months. So symptoms and progressive signs, especially signs of invasion of the orbit, are all ominous signs, and that was confirmed by an imaging as well that showed orbital invasion with localized scleral involvement. And I did a biopsy, and the initial biopsy showed that it was again a differentiated, moderately differentiated invasive squamous cell carcinoma, and also did a systemic metastatic workup. And fortunately, the systemic metastatic workup was within normal limits, and there was no obvious metastasis at that point of time. So went on to treat it aggressively and proceeded with an orbital exenteration. And the exenterated specimen was once again sent for histopathological confirmation for tumor clearance, and also simultaneously gave cryotherapy to the apical soft tissue. And the right socket was reconstructed by a myocutaneous advancement flap. I normally reconstruct sockets with flaps rather than grafts for allowing good vascularity of this socket. So that's the heel socket that you see at 3 months post-op, and that's with the process in situ. And this was just a lesson not to neglect an OSSN. And another very, very neglected OSSN, this patient unfortunately came with cerebral metastasis, simply because he had neglected his OSSN for more than 3 years, and he was just referred to medical oncology for palliative treatment, and we lost the patient 6 months later. And it's a very unfortunate case, so it's just for the audience to remember. And sometimes we also need to look at pre-malignant skin conditions, and we need to try and correlate them if they could be predisposing risk factors. So that's the reason why I presented the face of this gentleman. And as orbital surgeons, we always start from the face and then narrow down to the eye. So this gentleman had a diffusely infiltrating ocular surface squamous neoplasia clinically with compromised vision and extending the entire ocular surface, also extending down to the fornices as well, and the caruncle, suggesting a gross invasion of the orbits as well. And this patient, on facial examination, he had multiple patchy areas of depigmentation with hyperkeratotic or pigmented borders. And I sent him to dermatology for an opinion, and dermatologist also wanted a tissue diagnosis from the skin. So I proceeded to do a skin biopsy as well as a conjunctival biopsy. The skin biopsy showed a discoid lupus erythematosus, and the conjunctival biopsy showed an invasive squamous cell carcinoma with orbital involvement that was demonstrated by high-resolution CT scan of the orbits, which was also done in this patient. And then we proceeded with left orbital exenteration. That's the picture that you see there. And after exenteration, I also did a flap closure. And in this case, because I had to remove the eyelid tissue as well, because everything was involved, so I had to do an extensive exenteration. So I had to do a flap, composite flap in this case. So composite flaps are nothing but 2 flaps that are anastomosed to each other to vascularize the socket. So that's a glabellar rotational flap I've done on one side, and I've also mobilized tissue in a tensile fashion to anastomose the 2, and that's the socket that you see at the end of 2 months. And it's healed quite well, and that's the chap after his process fitting. And he was then re-referred to dermatology for treatment of his cutaneous lupus condition. And this gentleman is a 54-year-old male who presented with who has a history of previously treated squamous cell carcinoma on the right lateral tongue. And that subsequently, after about a year, recurred to involve the oral cavity. And again, he underwent wide excision with reconstruction with right-sided radical cervical lymph node dissection and adjuvant therapy. So that's the gentleman that you see. When you obviously observe his face, you can see that he has had extensive surgery in the oral cavity, and his entire lip has been resected on the lateral aspect, right lateral aspect, and that's been replaced by a free flap that's in situ. So always as orbital surgeons, when we want to look for any clues of what we are dealing with in the eye, we sometimes will have to start with gross features and then subsequently narrow down to the eye. Like in this gentleman, the reason why he was referred to me was because he also developed an ipsilateral conjunctival nodule. And that was suspicious, and it was clinically it presented like a limbal OSSN 1 year after he has had his oral surgery. Now, this gentleman also had a family history of squamous cell carcinoma of the larynx in his father, and that is again a subtype of head and neck cancer. And he himself was a chronic tobacco user, and in between the two metachronous tumors that he had, the initial tumor in his lateral aspect of his tongue and the subsequent one in the oral cavity, between the two metachronous events, he had COVID infection, which probably also pushed him towards immunocompromised status. Now, when I did a biopsy and treated this lesion, did an excision biopsy, again cryotherapy with AMG application, and found that it was a metastatic deposit on histopathology, and that showed the same histopathological picture as the head and neck cancer. And he was then referred to medical oncology for a PET scan and systemic metastatic workup and palliative therapy. So summarizing, ocular surface tumors are a wide spectrum ranging from benign to malignant lesions. Early diagnosis and prompt treatment can be rewarding, and they can be potentially sight-threatening and life-threatening if they are mismanaged or neglected. So I don't know if I've done full justice to the topic. I've just tried to cover a brief overview. Open to questions. Thank you.
Thank you for a wonderful and informative talk.
So I will try to finish it off fast. Basically, small pupil, not a big deal. We have fantastic surgeons sitting here, and they routinely do it. And we know we have lot of possibilities, lot of ways how you can handle a small pupil case. But basically for the youngsters sitting over here, what I want to convey through this small presentation is that sticking to the basics is very important. So through this video, I will convey, I didn't use any accessory in this case. A 58 years old female, she was a little uncooperative, and I started doing topical. Pseudo-exfoliation was there, so pupillary construction was expected. And so here what I did, I kept the trench to the center. Along with that, I didn't disturb any of the cortical frills that is lying there. That was very important. I will show you at the end why. Multiple nuclear fragmentation was done, and because of jerky movements, the hold was breaking repeatedly. That's why you see 2 or 3 attempts in holding the nuclear fragment. And once I took out couple of fragments, the pupil came down heavily. And there the story begins. So you can see after emulsification of this portion, now pupil has come down. So here you have to take all the precautions in the form of accessories, pharmacological or accessory devices that you use. But I proceeded with the basics. I rotated the nuclear fragment to bring it in front of phaco-tip. That bare PC is not there in the front. PC is protected. I retracted the pupil manually to bring out those fragments which I had divided into multiple small pieces. If I had not divided initially into multiple small pieces, it would not have been possible for me to emulsify at this stage. Here also, if the fragment is larger, I kept dividing into more small pieces by lateral fragmentation, whatever you say. And you see the phaco-tip is very steady. It is lying well in the center. It is well in the pupillary plane almost. Why? You can see just by little bit bend down, the nuclear fragment came. So it is not very up, as it may not be visible here. and the emulsification was completed. As the more nuclear fragments were emulsified, at this stage you see what I do. Routinely I use Kelman tip. I made the bend horizontal so that the bend of that Kelman tip is not going to damage the PC. And this way I proceeded. Towards the end, if little bit soft cortex or epinuclear cortex piece is there, I used IA to prolapse that piece into the anterior chamber. I coated well with viscoelastic, and then I phacoed that portion with little or almost negligible phaco power, so that cornea is not damaged. This kind of pieces you can very well eat up by mostly by vacuum itself. And here, as the cooperation, uncooperation increased, I used adrenaline and xylocaine here, and completed the cortical aspiration and implanted the lens. So the take-home message is, if you keep your basics right, it is always, I'm not saying this is the way to handle these cases, but one bad day you may be lying in this kind of situations. So if you stick to the basics, even at any stage of your career, it will always be helpful to you. Thank you.
Thank you, Dr. Sujit, for such a wonderful presentation and to be precise on time. Thank you. So with this session ends, and I give the mic and the podium to Dr. Kunal Kishore for the next session.
To the industry sizzlers. So without wasting much time, may I welcome the chairperson of this session, Dr. Nagendra Sharma sir, Dr. Pradeep Karak sir, Nageshwar Sharma sir, Dr. Nilesh Mohan sir, Dr. J.J. Agarwal sir, Dr. Pooja Sinha ma'am, and the panelists, Dr. Navneet, Dr. Abhishek Anand, Dr. Gautam, Dr. Sanjeev, and Dr. Sachin, and Dr. Ranjan Rai as a chairperson. May I welcome them on the stage? Dr. Vishal, who will be giving a presentation on acryl insert and advanced monofocal IOL.
Over start, I think. We are already late. So good afternoon, everybody. I would like to thank Biotech for this sponsored talk. So coming to the topic of ADOF, that is what they have christened as acryl insert, advanced monofocal IOL, added intermediate vision. So basically in this slide, we see how the natural lens, what all distance they cover, distance, intermediate, near. Then in the monofocal lenses, they cover the distance and slight intermediate. Then we have bifocals, which covers distance and near with slight compromise. Then we have trifocal multifocals, which covers distance, intermediate, and near, but there's a compromise. And then the newer technology, ADOF lens, that is the extended depth of focus, and they cover the distance, almost it is equivalent to what the monofocal lens give, until intermediate distance, about 57 centimeter. And in our practical experience, we have seen if you give up these patients around plus 1.25 or 1.5 addition, then they can see the near very sharp. So it is a good option. Those means even if the patient is implanted with a monofocal IOL in one eye, we can go for this ADOF lenses. So there are different types of ADOF lenses. And coming to the theory part, the human eye is having a range of accommodation from 6 meter 25 centimeter and beyond 6 meter and below 25 centimeter. Eye won't change its shape. And with the age, the property of accommodation will reduce, and there's this loss of ability to focus the near object. And the further progress in the cataract reduces the transmission of energy through the eye lens, and so the accommodation further diminishes. So what is the possible solution to replace the cataract lens and achieve the accommodation property of the eye which we naturally have? So the answer to this is implant a intraocular lens, means who can achieve a partial accommodation property of eye. Now, as we have discussed earlier slides, what all the monofocals lens give multifocals, I will skip the slide. So just to achieve the natural vision, that is a continuous range of vision with a functional intermediate and functional near vision, many companies have come with the options. And biotech has given us this option of extended depth of focus named as ICL SUT. So what is the basic concept of EDOF-IL? Basically, this is for the treatment of presbyopia, and in contrast to multifocals and other monofocals IL, which have a specific focal point. Like in multifocal, we have this focal point. In monofocal, we have a specific focal point. But in EDOF, you have a elongated focal point. So you have a range of vision. So basically, the gap which was there, this is filled by the EDOF lenses. It has an extended depth of focus as shown in this picture. In the first picture, you can see the monofocal IL. You have a specific foci where you will see the image. So the image is sharp and monofocal. In multifocal, you have different foci for the intermediate, near, and far. And there is definitely compromise. Apart from this, they have glare and halos. In EDOF lenses, you have that elongated foci. So you have means range of vision is more from near to intermediate. And it's a clear, means the distance vision is comparable to the monofocals. So coming to the what all you expect from an EDOF lens, both intermediate vision and near vision is required, and it should be in our vision. There should be no minimal effect in the distance vision. So whenever we see which EDOF is suitable, so these criteria should be filled. Depth of focus should be more than 0.5 diameter. Then you should have a good distant corrected intermediate visual acuity and a best corrected distant visual acuity. So the possible solution for this, what the biotech group has bought is ICL SUT, and they have given this monomore technology. So what is monomore technology? They basically gives enhanced intermediate vision without compromising far vision. Then photopic phenomena comparable to monofocal segment, intermediate vision up to 57 centimeter and extended range of vision. So this was inspired, basically this concept was inspired by the natural vision, and basically they give an aspheric surface and spectacle independence for intermediate vision with extended range of vision till greater than 1.75 diopter. And the photopic phenomena is minimal, means it is comparable to monofocal IL. And it is the first preloaded advanced monofocal IL in the market. And basically, the unique feature of this EDOF by biotech is their unique jonular asymmetric power distribution on aspheric design. Means when you implant the lens, first go you will see there's multiple rings. Means I also asked them why you have, means when I have implanted the IL and I was seeing in the microscope, you see many multiple rings. But basically these are not rings. It's a completely monofocal IL. They say this is basically to just ablate all chromatic aberration and those things. To negate those things, they have made this. So coming to extended range of vision for intermediate distance without compromising the far vision. So this unique jonular asymmetric power distribution, optimized refractive zone to provide extended depth of focus, asymmetric power distribution to provide less pupil dependence, and photopic phenomena. There are minimal glares and halos. So thank you. So this is the new concept, and we should welcome that. Thank you.
So next.
Once again. So I would be talking on one of the new lenses which are available nowadays, the preloaded lens from the Hoya company, that is Nenex. So you all know that the cataract surgery nowadays has become a refractive procedure because of the patients' higher expectations as well as the advancement in technology in the machine and in the intraocular lenses. The intraocular lenses, we all know the material wise, it has improved a lot, and not only that, the way we implant the lens has also changed a lot. And this is now the era of preloaded lenses. So coming to the Hoya brand, Hoya company as such, the first preloaded lens, it was launched in 2001 by a Hoya company, which was quite good. And with time, it had evolved into various kind of lenses. One of the prime lenses is Vivinex, and recently in 2019, they have come up with a new lens that is Nenex. And the USP of the lens is that it can go through the sub 2 millimeter incision. So why it is important to have preloaded lenses? because we all know that with the cartridge injector system, we can sometimes land up with a lot of problems also. It is unpredictable. There are potential risk of complications. Like in this patient, you can see that it suddenly came out of the cartridge and hit the posterior capsule and the lens was about to sink. This is not the only complications, but it can lead to stuck IOLs, amputation of the haptics and others, so many things. And also requires the cleaning of the instruments, the injectors, the chances of sterility is compromised, and there can be some impact of the cartridge on the IOL itself. So the preloaded lenses actually eliminates the unnecessary steps in the preoperative, intraoperative and post-op situations. And the Hoya preloaded system, one of the best, I would say, one of the best manual injector system, preloaded system, where it gives the ultimate sterility. There is no human touch, and from manufacturing to implantation. So there is always chance of there is always a high chance of not getting any contamination during the implantation. What are the core values of the Nanex lenses? It has got the proven hydrophobic materials. It decreases the PCO reduction because of the proprietary active oxygen processing and treatment. Wound protection because it can go through the even 1.8 millimeter of incision. It has got very smooth and consistent delivery system, and it is one of the lenses having 4 types of way which can be used. Like you can use the rotatory motion, or you can just push it. You can implant in the bag by just adjusting the tip of the lenses. It's your choice. If the surgeon is compatible with just hydro injection, then you can just push the lens, or you can use the rotatory movement to implant the lens in the bag. The USP of the lens is that it has got active oxygen processing treatment on the posterior surface, as well as that it can go through the even 1.9 millimeter of incision. The PCO inhibition is by the active oxygen processing of the lens, of the posterior surface of the lens, which actually decreases the chances of the PCO in the lenses, which is again less in this lens because of the square edge design and sharp edges. And this was the study in the rabbit eye, where it shows that the lens without any oxygen treatment had more chances of PCO formation. So there is always value of a small incision surgery in phacoemulsification. So this all depends on how much is the nozzle size, what is the diameter of the nozzle in the case of any preloaded lenses. This Nanex actually can go even less than 2 millimeter of incision, but 2.2 millimeter incision, we generally don't do any phaco surgery. So with 2.2 millimeter incision, it can go easily without causing wound stretch. So there are less chances of operative astigmatism, less chances of post-operative infection theoretically, and there is early recovery of the patients after the surgery. So this is the nozzle diameter of the Nanex lens vis-a-vis the other lenses of its manufactured lens, like ISERT. It can go through 1.8 to with the Babynex, it can, even the nozzle diameter is 1.7, but the smallest nozzle diameter of the in the world is of the Nanex preloaded lenses, that is 1.62. That enables the lens to go through even 2.2 millimeter of incision below that. So this is just comparison of the various hydrophobic lenses, the size of the nozzle, and Nanex always scores over these. This was a porcine eye comparative study where it has shown that other lenses can actually stretch the wound to more than 2.2 millimeter incision if you implant it through 2.2 millimeter incision. This is the comparative study in the porcine eyes, where it was compared with various other lenses like iTech, Ultrasert, CS, Spina, and it has shown that there the chances of wound stretch are more as compared to the Nanex lens. This is a small video clip in my study. I have done 20 eyes in various preloaded lens implantation. I have measured the wound size and I could see that Nanex, there is no stretching of the wound. It always goes through less than 2.2 millimeter of incision. This small video just to demonstrate that. This study was done but at our center. I measured the wound size before implanting the lens and after implanting the lens. This is the Ultrasert lens. It also is this is also very stable lens. It doesn't cause much enlargement of the wound, but again, it can extend a little bit. This is the ISAT Hoya long back. It actually caused some stretching of the wound, even up to 2.5 to 2.6 millimeter. Another Lucia from the Zeiss company. It again causes some stretching of the wound, 2.5 to 2.6 millimeter. And recently launched the preloaded lens of the Technis. Again, this lens also doesn't go below 2.4, 2.5 millimeter incision. So all these lenses can actually stretch the wound a little bit if you consider the wound size as one of the parameters. So this is 2.5. This is the Nenex lens, which is being implanted here. The lens is very smooth. The design of the lens injector is such that you don't require more than a half minute to just load, just inject some visco and then remove from the casing and just push it forward, slide it, and then implant it. You can implant it under irrigation also, and the implantation is very smooth without any problem. Most of the time it goes into the bag. And the wound size, here you can see that it has not crossed 2.2 millimeter. So that is very important. I won't take much time as advised by, as ordered by our moderator, it has to be finished. So just one more slide. There is always, the delivery is always very consistent, very much consistent, and 100% time it ensures that it goes inside the eye without any problem of lens stucking or breaking of the haptics or anything else. And this was the comparative study just to see the ease of the insertions. This is a small 30 seconds clip just to say, so that even if there is posterior capsule rent, you can still implant the lens if there is sufficient support in the posterior capsule. Without stretching the posterior capsule rent, it can be there in the bag. So this is just to show one small clip. So you can use this lens very much confidently without any SLs. And just to say that this is again manual, but there are some other lenses available, autonomous, automatic preloaded lenses are available in the market. But if you consider those lenses, it comes with a little cheaper price. And among all preloaded lenses, in my experience, out of 450 lenses used in last 1 year, this is one of the best. Thank you very much.
Thank you, sir, for the wonderful talk. So
Speaking on sustain complete. So dry eye is one of the most common thing which we see in our OPDs. So this disrupts our, impacts every aspect of life, like physical health, sleep health, psychological, and level of independence. It affects reading, driving, and other daily course. This has been comparable to other disabling conditions, so its rating is quite high. So it is difficult to diagnose because of variation in tests and everything. So most people have moderate to severe dry eyes. The objective tests were applied for diagnosis, so most of them had moderate dry eyes. It is a frequently overlooked and underdiagnosed distressing problem with patient having a lot of symptoms and doctor not seeing anything. So we have debatable things on dry eye in history, and so many studies are done on dry eye. So we'll discuss a little on aqueous dynamics and dry eye. So we all know there's a mucus layer and a lipid layer. Mainly the lipid layer protects and maintains the tear film stability and works on mucoaqueous layer to prevent evaporation and collapse. So we know there's aqueous deficient dry eye, evaporative dry eye, which forms the major bulk of dry eye, and a mixed dry eye. So, so many factors, risk factors are there. Mainly, we know computer vision syndrome, male sex, 21 to 40 years of age, which are almost on computers more than 4 hours a day. Management of dry eye is vast, which includes basically the relief of symptoms for the patient, to prevent corneal damage foremost, and to improve patient's ocular comfort, to return the ocular surface and tear film to the normal state. So we have many treatment strategies, like the first one being the ocular tears, then non-preserved ocular lubricants. Then tea tree oil in case of, we have, if meibomian related, it works very well on my MGD cases to secrete the meibomian secretions. And then anti-inflammatory agents. Autologous serum is usually not practiced these days, and in extreme cases, we need to start on topical steroids and AMG grafting. And punctal plugs in cases like Steven Johnson and those with a lot of keratinization. So treatment strategies by treatment layer affected. We use cyclosporins, as I told, steroids and ribamypide off lately for ocular surface inflammation. Artificial tears can be considered as a first-line treatment. They are typically buffered solutions that contain electrolytes, surfactants, and one or more viscosity agents or lubricant. Artificial tears have shown to increase tear film stability, determining whether the major cause of an individual's dry eye disease, predominantly to aqueous tear deficiency or to evaporative cause or both, to treat the critical in helping select the most appropriate management. So coming to the topic, Sustain Complete. Sustain Complete is a newer generation artificial tear which actually takes into account the lipid layer as well. It works on lipid layer and mucoaqueous layer of tear film, increases lipid layer thickness, and there's a high patient satisfaction rate. Other ingredients are, as mentioned, the most important one being HP guar. So if it is a lipid-based, we might think that there'll be blurring of vision after putting the drop. But due to nano-sized particles of lipid droplets, they replenish the lipid layer of the tear film and they get scattered over the surface, hence not causing blurring of vision. HP guar increases mucus layer thickness, protects the ocular surface. So the HP guar is a hydrophilic molecule, and it makes a meshwork on which the once in the eye, the HP guar, there is a cross-linking with borate, aiding in retention of the demulcents and enhancing tear film stability. So it spreads across the, as I discussed, across the ocular surface. The small nano-sized lipid droplets cover more ocular surface area. HP guar forms a hydrophilic meshwork, cross-linking within the mucoaqueous layer, creating a protective elastic matrix, and nano-sized lipid droplets migrate to replenish the top lipid layer of the tear film, hence the patient is comfortable. So there have been many clinical trials for the same. There have been studies of Sustain Hydra and Sustain Complete, in which both of them proved right, but in lipid deficient or evaporative dry eyes, Sustain Complete showed better outcomes. So the summary is that dry eye is a common condition. Dry eye affects all aspects of life, and dry eye is difficult to diagnose despite advanced technologies. However, no lipid-based dry eye treatments were available till date. Now we have Sustain Complete, which is a lipid-based treatment for dry eye disease. So Sustain Complete provides quick and sustained improvement in dry eye. So these are a few of the patients. Thank you. I'll show a few of my patients in which I've tried, if I have time. Okay, so post-transplant also I feel it helps a lot. In patients with epidefect and in graft infiltrates also, and with those keratinized meibomian orifices like SJs, I'm using Sustain Complete. Thank you.
Thank you for a wonderful presentation. May I call Dr. Gyan Bhaskar sir for drug master file.
Panelist. Thank you, Dr. Kunal. I'm here on behalf of Mankind, drug master file. Mankind going to launch this guideline, Mahaflox eye drop, recently. What is the drug master file? The drug master file covers all the comprehensive, accurate, and precise information about the active pharmaceutical ingredients or the finished product doses form. Why DMS is important? Because it gives the information regarding the chemistry, manufacture, stability, purity, impurity profile, packaging, and current good manufacturing practice status of any human drugs. And also contains about the complete, factual, and correct information about the API. Why companies file DMF? Because play a crucial role for the manufacturers of the drug products and the support the documents of drug products, registration and approval. Regarding the DMF information, it is two types, open part and the closed part. That is the open part means the applicant part. It contains all the information to assess the quality that license holder required and submit the license or amendment application. The restricted part, the closed part, contains the confidential information about the manufacturing procedure, which is only disclosed to the authorities. In the current global scenario regarding the DMF, it is with the highly regulated markets in the United States, Canada, Japan, Australia, Europe. China develops its own DMF system. Recently, newer countries has included in this, the Russia, South Africa, and Brazil. But in our country, it is less regulated market. DMF submission type is in other countries, in the USA, there is the US FDA, in Europe, the EDQM, and in India, CDSCO, this is the MA Marketing Authorization Application. Submission type is 5 type. Type 1, manufacturing site, facilities, operating procedure, and personnels. Type 2, the drug substance in, intermediates, material used in their preparation and drug products. Type 3 is packaging material, and type 4 is excipient, colorant, flavor, essence, or material used in their preparation, and type 4 FDA acceptance reference information. DMF in India, there is no drug master file guideline issued in the Indian regulatory authorities, Central Drug Standard Control Organization. In India, generally, United States DMF format is used to submit confidential information to drug substance and drug products to regulatory authorities. DMF declared by the companies provided complete details of manufacturing place, physiochemical properties, toxicology study, pharmacodynamics and kinetics, therapeutics classes, dose form, strength, route of administration, labeling, and packaging. Summarize that the DMF contains the factual and complete information about drug products, chemistry, manufacture, stability, purity, impurity profile, packaging, and the GMP status of any human drugs. The main objective of DMS is support regulatory requirement of medicinal products to provide the quality, safety, and efficacy. Thank you so much.
Thank you, sir.
Thank you, Mankind, for this talk.
Thank you, sir. May I call Dr. Ashish Sharma for understanding.
Thank you once again. And in the interest of time, we'll try to skip few slides. So just before I start my talk, how many of you are biosimilar users in this hall? Okay. How many of you are user of Resumab? How many of you are user of Renize? How many of you are user of Renizurel? Got it. So means we have been tracking biosimilars since last 4 to 5 years. These are my disclosure. These are all biosimilars companies means across the globe. And I do have financial relationships with a lot of biosimilar companies in India as well. This is our contribution. Means as of now, we stand tall with highest number of publications across the globe as far as biosimilars are concerned. And I'm truly humbled to say that one of our publication, which was published in BJO, is sitting as a policy document in Canada for biosimilar policies. So this is again our fantastic group from across the globe, with whom we work on biosimilars, because biosimilar is something new for the entire globe as of now. Means biosimilar are molecules which are not exactly the copy because, they cannot be same. Even if you take Lucentis, if you bring it from Europe, if you bring it from US, they would be different. So there could be different in some buffers or some other component, but they have to make sure that regulatory wise, they should not be clinically different in terms of safety or efficacy. Predominantly, you have a cost benefit because that's what they provide. So only ranibizumab biosimilars are approved at this point. Aflibercept would approve after 2025-26. So as of now in India, just to clarify this audience, there are only 3 manufacturers. Intas, which manufactures Razumab, Renize, manufactured by Lupin, Renizorel, manufactured by Reliance. But sometimes you might have heard Osiva. Osiva is not a manufactured a single molecule. It is marketed by Sun, same molecule which Lupin produces. Vizumab from Cipla, again, same molecule which Reliance produces. So those are not different molecules. Japan has another molecule, US has another molecule, UK has molecule, Europe. So entire world ranibizumab biosimilars are approved. Now the question is, how would you differentiate? Which one would you like to use? You see, the different number of patients in different trials. So sometimes this takes away the confidence from a lot of people that these are not safe molecule. But you should not think that way. So why? Because you need to see the real world data. Real world data is as of now highest with Razumab because it was approved in 2015. This was a paper that we published for Renizorel. It found, means absolutely fine. Now Renize, which is now, I am a predominant user, 15,000 injections are given and we are working on the real world data of around 200 injections. So is there a differentiator for clinicians? All the molecules, they work. The only difference is you have a molecule, Razumab, which is, being used for, quite many number of years. So you have much more confidence in that. Now, Renize numbers are also pretty high. My personal experience is great. So I'm sharing some of the cases which are predominantly with Renize. This is a DME case, responds very well. This is just to show you that these drugs are really, really efficacious. Because safety-wise, do not hesitate. Because now endotoxin limits are so tight that you will not find safety issues, I'm telling you, with any of the biosimilars. Again, DME case responds very well. After then, again, 1 month it recurs, but again, you have to shift these patients because of some of other reasons, but still, this is just the response of that, how biosimilar, whenever these patients are, how do they respond? Renize, after 1 injection, then edema reduced, but not again completely reduced. But as I said in my DME talk, do not try to dry completely. 6-9, patient does not feel any discomfort, observe it. Again, another case, similar case, RVO, retinal vein occlusion, again responds very, very well after 1 injection. Another recurs after a month, again after injection, does very well, and shifts to Avastin. Again, when it comes back to 6-9-6-6, we observe. Again, another RVO case. This is a neovascular AMD case. You see a lot of hemorrhagic PED, which responds very well. You see, look at this difference at OCT. Everything dries up. So this is all, the efficacy of the drug, that how great efficacious these drugs are. After 2 monthly injection, parapapillary CNVN completely vanished away. Again, another means this was a very interesting case. I do not still know that what this patient we were treating with 10 Avastin injections. This was a CNVM, but somehow at one point it developed this kind of, this you sometimes see in, some kind of tumor or something, but probably for me it was a large choroidal vessel which responded amazingly after 1 injection. So regarding safety, do not worry. Look at the Europe, which has maximum experience in biosimilars across the globe. Since 2006 till now, there is no molecule across the globe, biosimilar molecule, which has been suspended or withdrawn because of safety and efficacy reason. What next? Brolucizumab could be another candidate for BioBetter. I'm not going to detail about BioBetter because time is restricted. So the future of biosimilars is that you have so many molecules. And I'm announcing one point today, there is a possibility in future you might not see phase 3 clinical trials for biosimilars. This could be a large statement, unwanted statement today, but we might be talking maybe 10 years ago, 10 years ahead, but that might hold true. The same thing what had happened with generics. So education, understanding about these molecules is important. And last slide is, new assets, new molecules might be unpredictable rather than biosimilars which emulate a drug which was completely safe before. Thank you so very much. We can save many lives with these
Thank you,
molecules.
sir. Have you noticed tachyphylaxis in your cases? If
Divya, restoring ocular integrity of perforated corneal ulcer.
Good afternoon. My topic is restoring ocular integrity of perforated corneal ulcer using host tissues derived from keratoplasty. Aim of the study was to report initial clinical outcomes of therapeutic PK for perforated corneal ulcers using host corneal button. Therapeutic penetrating keratoplasty is a surgical procedure to restore globe integrity or to resolve infections or inflammatory keratitis non-responsive to medical treatment. COVID-19 pandemic caused unprecedented crisis to cornea surgeons. There was an acute imbalance of demand and supply of tissues. We report 2 cases that required therapeutic PK and were managed successfully by graft derived from host tissues of patients undergoing optical PK for PBK. Case 1, it was a 28-year-old female with a history of trauma with wooden stick of 6 days of duration. Patient had a complaint of redness, discharge, decreased vision in right eye and was previously treated on eye ointment itraconazole, moxifloxacin eye drops, tobramycin eye drops and eye ointment atropine 1% with no symptomatic relief. Systemic examination was within normal limit. Ocular examination, patient had right eye vision was hand movement close to face with PR accurate in all quadrants. Cornea had a perforated corneal ulcer of greatest diameter of 5.1 into 4.2 mm with 0.5 mm of diffuse stromal infiltrates in surrounding corneal stroma. This is the clinical picture. Anterior chambers was shallow inferiorly and fundus had ultrasound B scan was done which was found to be anechoic. Preoperative investigations were done. Patient viral markers were non-reactive and gram stain was negative. Coach wet mount had filamentous septate fungi and Sabrod-dextrose agar has Aspergillus species. Patient was started on medical management with eye drop natamycin, homatropine, moxifloxacin and tablet ketoconazole twice daily. Therapeutic penetrating keratoplasty with intracameral injection of voriconazole was performed using glycerine-preserved non-vascularized host tissues obtained from optical PK of PBK patient with size of the graft was 7.5 mm. On post-operative day 1, graft clarity was 0 and graft host junction was well opposed. Anterior chambers was formed and patient was maintained on same medications as advised preoperatively. This is the post-operative day 1 picture. Patient was followed up weekly for next 1 month. Graft clarity didn't improve. The graft was completely epithelialized at 1 week. There was no recurrence of infection. Follow-up through telemedicine services was done. At 1 year, graft was completely opaque with inferior conjunctivalization over the graft. Anterior segment OCT was done with Topcon DRI OCT triton preoperatively, which was suggestive of thick epithelialized graft with opposed graft host junction. This is the clinical picture at 1 year. Optical PK was performed after 1 year. Final visual acuity at 1 month post-operative visit was 6/36 parts with a phakic correction. Histopathological examination shows stratified squamous non-keratinized 5-layered epithelium. These are the pictures for case 2. In February 2020, a 68-year-old female presented with complaints of redness, pain, photophobia, and decreased vision in left eye for duration of 1 month. On examination, visual acuity was PL positive, PR accurate in all quadrants, and cornea had perforated corneal ulcer of size 4.7 into 4.5 mm with Descemet's membrane folds and shallow anterior chamber. This is the preoperative picture. Fundus had no glow. Preoperative examination, viral markers were non-reactive and gram stain was negative. KOH wet mount had filamentous septate fungi with Sabrod-dextrose agar has Aspergillus species. Systemically, patient was well. Patient was started on the same medical management as patient 1 and therapeutic penetrating keratoplasty with intracameral injection of voriconazole was performed using glycerol-preserved non-vascularized host tissue obtained from optical PK of PBK patient. Size of the graft was 7.5 mm as well. Post-operative day 1, graft clarity was 1+, host graft junction was well opposed, anterior chamber was formed and AC details were faintly seen. The patient was maintained on same medications as advised pre-operatively. No exudates or hypopyon was noted. This is day 1 picture. Patient was followed up weekly for first 3 weeks. No recurrence of infection was noted. Graft was well epithelialized at the end of 1 week. Due to widespread pandemic, he was followed up by telemedicine. At 1 year follow-up, the visual acuity in left eye was perception of light with projection of rays accurate in all quadrants. Graft clarity was 0 with deep vascularization at 4 and 5 o'clock positions. This is 1 year picture. ASO-CT at 1 year was suggestive of thick epithelialized graft with peripheral anterior synechia superiorly at graft host junction, while anterior chamber was formed. Optical triple procedure was done at 14 months when donor tissue became available. Patient's final visual acuity was 20/80 at 1 month post optical penetrating keratoplasty. These are the clinical pictures. During lockdown, the number of donor cornea collected and thus emergency therapeutic keratoplasties performed decreased significantly. Tissues from other eye banks could not be transported. People started using glycerol-preserved corneas or scleral patch graft for therapeutic purposes. We anticipated tissue scarcity due to COVID-19 pandemic and promptly preserved 4 host tissues derived from optical PK in glycerol. Tissues were utilized on day 8 and day 6 and day 8 of their storage respectively because even glycerol-preserved corneas were not available. Take-home message: therapeutic PK using host tissues obtained from recipients of optical PK is safe and effective option to restore ocular integrity in case of emergency during shortage of fresh or glycerol-preserved corneas. Optical PK is required for visual rehabilitation later. Thank you.
Thank you, Dr. Divya. Any questions? Open to panelist and chairperson.
Good afternoon, everyone. I am presenting a case report of 15-year-old male patient who presented with diminution of vision in both eyes, right more than left since 2 months. BCV on presentation in right eye was 1/60 and in left eye it was 6/60. There was no history of systemic illness. On examination, both eyes had chronic rhegmatogenous retinal detachment. Firstly, scleral buckle with cryotherapy was done for left eye, which was the better eye. Then after 2 months, right eye was operated and scleral buckle with SRF drainage and cryo was done. But there was persistent SRF inferiorly and at macula for more than 6 weeks. So patient again underwent pars plana vitrectomy with endolaser and silicone oil injection in right eye. On post-operative day 1, I saw there was cells in anterior segment, 2+ cells was there, and on fundus examination, there was fibrinous kind of membrane over the optic disc with attached retina under the silicone oil. At that time, the best corrected visual acuity was at finger counting at 1 meter. I started the patient on oral steroids, 1 mg per kg, and he was already on systemic antibiotic post-op. But to my surprise, I thought initially oral steroids was started post-op day 1 because I thought that fibrinous reaction is due to intense laser which I did intraoperatively. So steroids was started, but to my surprise, on post-op day 3, this fibrinous kind of thing became more like exudate, and it was on the disc and over the arcades with best corrective visual acuity of finger counting. Half meter and PR was accurate. I stopped oral steroids and shifted the patient from ciprofloxacin to doxycycline. I'll tell you the reason why I did this. So on OCT, we can see the hyperreflective clumps over the disc area, and which is more confluent. And here we can see retinitis involving the inner retinal layers. So that was the reason I started the patient on doxy. I was not quite clear whether it is early end of or whether it is concomitant retinitis post-surgery. So this was the picture on post-op day 3. And I could also see, it is not clear in this, but there are clumps above the silicone oil interface. We can see the silicone oil interface there on OCT, and above that there are clumps. So that could be the turbidity or the contamination in the silicone oil. But on post-op day 5, there was no improvement and it has increased. The exudation has increased and the best corrected visual acuity has deteriorated to finger counting close to face. So diagnosis of endophthalmitis was made and silicone oil removal with vite lavage and intravitreal vancomycin with ceftazidime, and re-injection of silicone oil of different brand was done. Sample from vitreous cavity was taken and silicone oil was also sent for gram stain, KOH mount, and culture and sensitivity, but results were non-conclusive. Post-op day 1, although the media was hazy, but the retina was attached under the white oil and without any exudation. And this was the picture on post-op day 3. On OCT also, it was a settled retina, and although the fovea was thin, there was disruption of outer retinal layers, but the retina was attached, there was no exudation. This is post-op 1 month, and the vision was 2/60, and at 2 months, the vision was 3/60. And this is the OCT at 1 month. So I have never seen such type of case before in 5 years of my career. So I went through the literature, and I found there's a review on endophthalmitis following pars plana vitrectomy. It was published in 2014, and the cases were taken from 1983 to 2012, and they have compared sutureless with sutured vitrectomy. That was 20 gauge, which was used initially, and then we transitioned to transconjunctival sutureless vitrectomy, that is TSV, and they found that the incidence of endophthalmitis was much more in transconjunctival sutureless vitrectomies. The factors they enlisted were inadequate wound closure, hypotony, vitreous wick syndrome, surgeon's learning curve. When you transition from 20 gauge to 25 gauge, the incision should be more of beveled and valved incision. So if you make more of a perpendicular incision, the chances of ingress of microorganisms will be more, and thus the chances of endophthalmitis. And omission of subconjunctival antibiotic and inclusion of intravitreal antibiotics in sutureless vitrectomy has increased the incidence of this endophthalmitis. And patient-related factors obviously are the immunocompromised status, that is diabetes, trauma or excessive rubbing of eyes, non-compliance to the treatment. I have ruled out all these surgical causes, surgical-related risk factors in my case. The patient did not have any hypotony. I have cleared all the vitreous from the wound site, and I generally suture the wound because I use 23 gauge. So I sutured the wound, and it was a beveled incision. I had used subconjunctival antibiotics, and I have not used any intravitreal antibiotics in the primary surgery. Then comes the role of endotamponade. So endotamponade, whether it is fluid-filled or I have used any tamponade like air gas or silicone oil. So they say if it is fluid-filled or air-filled, the chances of infection will be higher. But in my case, it was silicone oil. And the silicone oil has this property. So, of antimicrobial property, because it mainly causes nutritional deprivation and toxicity of low molecular weight components to microorganism cell membranes. It has high surface tension and low permeability, so it limits the movement of pathogens, and it has an space occupying action, so it contributes to the washout of pathogens and their toxins by physiological mechanisms. So it is not moving.
Okay, thank you, Nishita, for a wonderful talk and enlightening us on endophthalmitis associated with silicone oil. May I call Sakshi
Dr.
Kumar?
Nikita, is there any difference between silicone oil filled eye endophthalmitis versus vitreous cavity in which the vitreous is intact? Do you think that silicone oil filled eye is going to restrict the inflammation in particular zone?
Inflammation, and the vitreous obviously is not there, so it won't be in the vitreous. So, but it can be dangerous because then the organisms may cause retinitis. Retinal inflammation will be more in vitrectomized eye as compared to the vitreous in which the vitreous has not been removed.
Thank you. So next talk will be Descent membrane detachment, a stumbling block for beginners in cataract surgery. Over to Sakshi.
Good afternoon, everyone. I'm here to present on Descent membrane detachment. I present to you a case of a 75-year male who came to us with the complaints of defective vision in left eye from past 2 months. He had history of cataract surgery 2 months back, and was using hyperosmotic drops since then. He was referred to us after 2 months of treatment. On examination, the vision in his left eye was finger counting close to face. Cornea showed epithelial edema, Descemet membrane folds with diffuse stromal edema, and there was a superior large Descemet membrane detachment extending temporally. As you can see in the image, there was a diffuse stromal edema involving the visual axis along with Descemet membrane folds. ASOCT was done for the patient to see the extent of the Descemet membrane detachment. Treatment history, patient was initially kept on conservative management. He was started on topical corticosteroids and hyperosmotics. He was also given cycloplegics. And since there was no improvement for past 2 months, he was advised to undergo desmetopexy with C3F8 gas. This is the procedure. A side port was created, and then after that, C3F8 gas was injected, followed by creation of an inferior iridectomy to prevent pupillary block. After 2 hours of the procedure, intraocular pressure was checked and was within the normal limits. This was the preoperative picture of the patient where vision was finger counting, and this was the picture on post-op day 1. As we can see, there was a significant clearing of edema with a vision of 2/60. Coming on the discussion, DMD is a focal or diffuse corneal edema with slit lamp evidence of Descemet membrane separation from the posterior stroma at the site of corneal edema. Epidemiology shows that in cases of SICS, there's chances of 1.5% cases develop DMD. Clinical presentation, the symptoms are decreased vision, watering, photophobia, and signs are non-clearing corneal edema and slit lamp evidence of DM separation from posterior stroma. Risk factors can be patient-related, intraoperative, or post-operative factors. Factors leading to DMD during small incision cataract surgery. Patient-related factors are shallow anterior chamber, pseudoexfoliation, dense cataract, deep socket. Steps during which DMD can commonly occur are during AC entry with keratome, during OVD insertions, and during nucleus delivery. How can this be prevented? By proper preoperative workup, by proper handling of the instruments, especially near the tunnel area and the side port area, and by slowly delivering the nucleus with enough viscoelastics. Descemet membrane detachment can be classified into loose and taut, unscrolled and unscrolled further into planar and non-planar. There's another classification, the Duas classification, in which type 1, there's involvement of pre-Descemet layer and Descemet membrane, DM detached, and type 3 is PDL plus DM detached. Management options depend on size, visual axis involvement, scroll, unscroll, taut or loose. In cases of planar unscrolled loose DMD, we keep the patient on conservative management, and the waiting period is 2 to 3 months. In cases of all other types of DMD, there's a requirement of manual repositioning, which can be done through a cyclodialysis spatula. A DM suturing can be done in cases of peripheral DMDs. Anterior chamber injection, that is mechanical tamponade, it can be non-gaseous through viscoelastic material, and gases, either 100% air, which is least effective because of a life of 3 to 4 days, 14% perfluoropropane, that is C3F8, or 20% SF6. There can also be a combination of anterior chamber gas injection plus surgical repair. These are some of the studies which showed the efficacy of desmetopexy in repositioning of the detached DM. This study was published in the Journal of Cataract and Refractive Surgery, which took around 14 patients, and there was successful reattachment of Descemet membrane and resolution of corneal edema occurred in all of them except one patient. Management algorithm of DMD based on slit lamp. In cases of during intraoperative DMD, we have to minimize manipulations and give air tamponade. In postoperative cases, in superior half, in planar cases, we give intracameral air, whereas in scrolled edges, we give intracameral SF6 and C3F8. Inferior half, whether it is planar or scrolled edges, we give intracameral SF6 and C3F8. If there's no help from desmetopexy, we have to do replacement of the detached DM, which can be either through penetrating keratoplasty or through desmet stripping endothelial keratoplasty. Thus concluding, DMD is a vision-threatening complication of cataract surgery. Most are unrecognized and get spontaneously attached. Risk factors should be recognized and careful instrument handling should be done by the beginners during cataract surgery, especially in hard cataracts. Anterior chamber injection of gas is the treatment of choice, and repeat desmetopexy should be tried before keratoplasty. Thank you.
Thank you, Sakshi, for the elaborate presentation on how to manage a descent detachment.
I'm Dr. Anita Ambas, moderator for this session. I welcome you all to this session 5 on Master Stroke session 2. I invite the chairpersons, Dr. Rajesh Tiwari sir, kindly come to the dais, Dr. UP Bhadani sir, Dr. UP Bhadani sir, Dr. Shekhar Chaudhary sir, kindly come and take your place on the dais, Dr. Nagendra Prasad sir, Dr. Shivendra Sai sir. And the panelists are Dr. Gyan Bhaskar, Dr. Amarnath Chaudhary, Dr. Sanjeev, Dr. Bandana Tiwari, and Dr. Nishit Prakash. Short of time. I'm not going to come between you and the next speaker, Dr. Ashish Sharma. He'll be talking on international fellowship, wings that make you fly. We've just heard him. He's an excellent speaker with vast knowledge, and I think one of the best persons to tell us on international exposure and how to get international fellowships. So I see a lot of PGs and residents here who will be having a lot of questions to ask from him.
Yeah, so I kept this, Mishra, that rather than having a didactic lecture, it's the realistic conversation. If anybody of you have any questions, I'm happy to answer. So it's a free conversation we would have for next 6 to 7 minutes. Anybody in postgraduates, you have any questions regarding, how to get into the international fellowship and what, what it does to your entire career? Anybody?
Yeah, can we have the mic there? Yeah, I think the first question would be probably why is it needed? I think this is one question which must be there.
Interactive session. So basically the idea is to sensitize our postgraduates that, well, we are in Patna, we are in Bihar. Maximum what we will think, we will go to Shankar Netralaya, we will go to LVPI, we will go to short-term fellowships provided by other centers. Arvind Eye Hospital? Wait. So, what our postgraduates should do to go abroad at this stage? To one who is doing senior residency, another who is still doing his junior residency. So, what is the way forward?
So before we talk about the way forward, I'll just tell you background that why it is important to have an international exposure. So international exposure, probably, India is a country of clinical volume. You have a large clinical volume in this country. And we are good clinicians, no doubt about it. But if you really see the way we grow right from the MBBS, MS, then fellowship, we never learn basics of, asking and challenging what exists. That is what you will learn when you are, exposed to an international system where you sit with the people who have devised classifications, who have given terminologies, and you see those residents and those fellows challenging their consultants right there. So the system, the way we grow is, this is written in Ryan's. This is written here. That is what I have to learn. So that thing becomes, that change happens when you go for an international exposure. You start asking and challenging those existing concepts Rather than, building a clinical experience for you, it builds a different kind of thought process for you. So you become an innovator in terms of your own clinical material. So being a good clinician, once you come back, then you see each and everything from a different perspective. So your perspective changes completely, so that once that perspective changes, your growth trajectory changes. It is not limited. And then, of course, you build great connections with those people. And then you keep working with them, you keep publishing, and you keep finding newer and newer things. So that, again, helps flourishing your career. Now, how to get it? Somebody was asking. Means this is the question which I was expecting, that, how do I go there? So the best way is you keep doing your training. For people who are in post-graduation, always I say, build your CV a little bit. And CV build-up happens over the time once you start publishing. US especially, because I was trained in US, it works on publication because there is no other way that assessor can check you, that you have done some significant work. So based on the CV, you are, judged. And so publish in some good journals which have higher impact factor. And then once you are done with that, you at least know the process. That, how to, submit, how to get review. So all those processes, once you are thorough, even if you have 2-3 publications, that's fine. That shows your inclination. And then try to find places that which place and what specialty you want to, build your career. Then try to find best people in the world in that specialty. Directly contact them. This is the beauty of, people who are outside. They would respond to you immediately if they have any kind of vacancy. And I would suggest, sometimes a mindset in our country for all postgraduates is that I need to cut. I need to cut there. You are cutting enough in this country. Go for a different perspective, even if you get it for 6 months or a year. You have entire life to cut tissue. But the perspective would change your life. That's what I would say.
So I think, when you go outside, you get a different perspective on things. You learn the way the world is working, right? You develop a questioning mind, and who better to tell us than the innovator himself? I think you might have, been asking these questions and learned how to ask these questions there. So that is very important, rather than just getting into a rut, of number of surgeries and that. And I think the second point which he said, which I feel is very important, is to get publications. Whether you are, would you suggest that in the GR-ship also while they're doing PG, or only in the residency?
At any point of time. I still remember, Dr. Rao's, LV Prasad head, when I joined LVP as a consultant, I still remember his one statement when he, takes his oration, that all my fellows, all my postgraduate residents, remember one thing, and I am telling you on behalf of him, these are golden words: find a specific area. It could be the smallest specific area. It could be a conjunctival vessel. It could be a smaller retinal tissue. Find your area of interest and publish 5 papers in a year. After 10 years, you will see yourself, you are sitting on top of the world. That is what happened with biosimilars with us. We have targeted the area, and over the time, now we are guiding the entire world in terms of policy formation, in terms of, overall guidance. So that wisdom, if you start from now, if from residency level, I started late. I think I would appreciate this girl. I would appreciate this girl in the way she has come up at this age. Means I have not yet interacted with her, but the way her CV was defined, she has gone on that path. You see her trajectory. So if you identify area of interest, then it makes a lot of sense. It takes you a different trajectory. You would enjoy it. You would enjoy ophthalmology. Because I have seen some people getting burnt out at 40, 45, this, daily cataract, what else I can do now? People burned out, that interest goes off. But once you are inclined towards something new which you can answer, then it is never boring. You can enjoy it throughout the life. You have seen stalwart Mangat Dogra sir, means so many people are there who have taken this trajectory. So to enjoy ophthalmology, start from now.
So you are never too young, you start off in JRship, develop an area of interest and then build upon it. So while you're doing a JRship even, you can, take out to do some good work and take out a few papers and then stick on with that. Is that true?
Absolutely true. And to get it means do not keep in your brain that, USMLE, if I do not have, I will not get anything. It's not like that. It's not like that. A lot of postgraduates have this thing in brain that, to step into US, I need to have USMLE. This is a myth. You can get into US fellowship system even without USMLE. If your CV is a little bit strong. And if you are persistent, what they see is, how driven this candidate is. Then you find a place. So finding a focused area, again I am repeating, find a focused area, because if you are diffused, people will not take you seriously. And that happens over the time. It's not that easy to find a focused area as well. But apply, directly contact those people. All those, university heads. Okay, he is working in the retinal degeneration area. Okay, I like retinal degeneration. I am writing an email to him. And they would respond. They are good in responding.
So when you're applying, you should concentrate on your CV. So, and you don't really, the important part is really don't need a USMLE or anything like that. You can directly apply. Your CV just needs to look, if you're applying for a retina or something, it should look as if, you are having some papers related to that topic on which you are interested. Only then they will be interested and they'll get back at you. So I think the next question will be, there are other things like different places are good for different things, like Singapore might be good for one thing. So in a broad way, do you have some idea which?
Yeah, means for example, US is very clear. Means if you really want your specialty, type on Google that top hospitals in ophthalmology in US. Okay, so you will find a list. For example, Stanford does not come on top. John Hopkins does not come on top in ophthalmology. What comes on top? POSCON Institute comes on top. And in that list as well, you will find that, this cornea, these institutes are on top. Retina, these institutes are on top. So that list is very easily available. So once you start doing your homework, you will automatically know it.
And I think the next important thing which they might want to know is about the financial aspect. Do they take fees? Or
yeah, that's a very important question. That's a very important question, that whether you have to be self-sustainable. So US is a country, means I was trained in US, so I know about US. I can guide you about that. I have never been into UK, so I do not know about that system. But any fellow, if you enter in United States, you will be paid. You will definitely be paid. University cannot keep you and take work from you. This is against the ethics. So they would pay you probably, it would not be, but as a bachelor or means, they would pay you at least $2,000 to $3,000, which is much more than enough. You can roam around the country. That's a good age to roam around the country, get international conference exposures as well. So you get money.
Oh, that's nice to know. So I think we now have a basic knowledge. Yeah, please do ask.
I just wanted to add a point. So sir has very nicely given an update on that. In addition to building up your CV and directly approaching the people with whom you want to do fellowship, you can also go through the exam system. So you can start with your ICO fellowships right during your JRship, or when you're a first year PG. Even when you have completed your first year, you become eligible for the steps of ICO and FRCS. And ICO every year does give fellowship grants to students for short-term 3-month fellowship as well as long-term 1-year fellowships. So once you start, if you start early during your JRship first year, by the time you're finishing up your final year post-graduation, you'll be able to complete your final step. There are 3 steps for ICO, and you can subsequently start applying for fellowships. So that's the other way out, where you can even get grants along with your fellowships.
So
And
very
for-
valid point that she has in terms of the finance. How do you make the balance the finance? So if you continue ICO provides you grants.
Yes.
So that way also you can.
Yeah,
So I
and
think-
other than ICO, if you want to go directly to UK for some fellowships, going through the FRCS and FRC off, if you have cleared those exams, the chances that you get a fellowship there directly while applying through the UK NHS websites, that is also an option. And they also do pay well for their fellows there.
So one way will be to clear the ICO, the FR, the fellowship exams, and then go. And the other would be to directly apply. So, one thing is not exclusive to the other. You can find your own path. And Dr. Ashish is there, Dr. Pranita there. You can always catch up with them in the lunch hour.
Yeah, you can actually speak to Dr. Setupati as well. He was us.
Thank you so much for this. And I think all the residents are free to contact Dr. Ashish, Dr. Pranita, and Dr. Setupati. You must be having a lot of questions. Be free to ask them. And thank you, chairpersons and moderators. We'll join again after the lunch. लंच के बाद फिर आना है क्योंकि लंच टाइम हो गया इसलिए ब्रेक कर रहे हैं लंच के बाद फिर
In this whole day of scientific extravaganza, we are now into a very important session of Dr. Ranjan Akari oration. And for that oration, we have our son of soil, Dr. Rajesh Sinha sir. So to begin with the session, I would like to invite the chairpersons for the session, Dr. Sudhir Kumar sir, Dr. Gyan Bhaskar sir, Dr. Rajesh Tiwari sir, Dr. Ajay Sinha sir, and Dr. Ranjana Kumar ma'am. Please come on the dais. Oration is not only about a presentation, it is much beyond that. It's about scientific deliberation, as well as the person who is deliberating has a special connection with the society. And most of us sitting here in this hall are somehow connected to Dr. Rajesh Sinha sir. Everyone has his own story. And to respecting that connection only, to introduce our orator, I'm requesting Dr. Nilesh Mohan sir to introduce our orator, Dr. Rajesh Sinha sir.
Thank you, Dr. Sujit. Professor Rajesh Sinha is a well-known figure before you. He has been here, he's a son of the soil, and you all know him very well. But yes, it is customary to introduce the orator. So he's presently as a professor of ophthalmology in cornea, lens, and refractive surgery services at RP Center, AIMS. And he did his MD long back in 1999, completed his DNB, has done his FIACL and FRCS, and did his fellowship at University of Washington. He is credited with more than 375 publications, 4 textbooks, and 5 educational manuals to his name. He has been part of 3 multicentric FDA clinical trials and received various awards, notable among which achievement awards of AAO, APAO, and South Asian Academy of Ophthalmology. He has been a prolific, I would say, a researcher, prolific clinician, and apart from that, he's a very good gem of a person, and he has received innumerous orations. And this time, we are here with him for the Dr. Ranjan Akari oration. So you should know that your son of the soil is this time contesting for the Secretary of AIOS. So presenting to you, Rajesh, over to you.
Emotional moment because obviously whenever I come to Patna, whatever time I spend here, it's really very valuable for me. And my childhood friend is also sitting here. And everyone, all of you, I mean, if I start taking names, I mean, all of you are so close to me. I'm extremely thankful to Patna Ophthalmic Society for giving me this honor, because we have been hearing about Dr. Ranjan Akhari since our, I would say, maybe childhood or maybe our MBBS days. And he was the past president of Bihar Ophthalmological Society. And what we know about him is that he brought intraocular lens to Patna and Bihar. I mean, he was the main person who popularized intraocular lens. And that is how we relate to him. That is how our connect is with him. He was born in Patna in 1949, then did his schooling from Patna, MBBS and MS from Rajendra Medical College and Hospital, Ranchi. Then he moved to UK and he learned his skills from various hospitals, including the Royal Infirmary Hospital. Then he returned to India in 1989 and he established the Drishti Eye Care and Research Center, which is a state-of-art dedicated eye hospital in Patna. Then he started many things, like he started in his hospital the fluorescein fundus angiography, retinal laser services, and of course phacoemulsification, the first ICL, collagen cross-linking, all these things he started. And he, unfortunately, he's no more with us, and it was a very untimely demise. And for his professional excellence and social commitments, he was honored by the Indian Medical, is what we know about him. And apart from all these, I have been in indirect touch with him. The first time I met him was in Sydney, in World Congress. And there, my ex-chief, Professor H.K. Tiwari, he introduced me to him. And otherwise, I was knowing him, but we never got introduced. And I was, after becoming ophthalmologist, I never met him. And I met him first time there only. And then after that, I had a couple of other opportunities to meet him. So I'm extremely fortunate, and I'm extremely thankful to all of you for giving me this opportunity to present the prestigious Dr. Ranjan Kumar Akhari oration. And since he was connected to intraocular lens, since he was synonymous with IOL, then I thought that the best thing will be that let's discuss, let's talk about the journey of intraocular lens. Like everything, like human beings, the intraocular lens has also evolved in terms of its material, in terms of its design, in terms of its delivery system, starting from increasing size of the incision, putting foldable lens by holder, by injectors, and all these things have come up. And the credit goes to Harold Ridley, who in 1949, he first thought that there were a few soldiers who were injured in the World War II wars, wherein the part of the canopy, the particles of canopy went into the eye. And these foreign bodies were removed mostly, but a lot of foreign bodies were still there in the soldiers' eyes. And when they came for follow-up, he saw that these foreign bodies are there, but they're not causing any problem to him, to the soldiers. So then he thought that, these are inert and these can remain there. And he left those foreign bodies. And then there was an incident that he removed the crystalline lens for a cataractus lens, and then his student told that you haven't replaced anything in place of it. And then he thought that probably the material that is PMMA, which is an inert material, can be placed in the eye in place of the cataractus crystalline lens. And that is how this concept came in 1949. And then over the next couple of decades, what happened that a lot of designs they developed, different materials were developed, made of glass, made of perspex, made of so many other materials, synthetic materials. And there was a lot of struggle going on. Until almost 1970s, the struggle was on to have the IOL in position. First, the posterior chamber IOL came into practice, and then it started falling back. So in the vitreous cavity, then they started putting it over the iris, then again went back to the posterior chamber lens. And then gradually over in 70s, they started having the IOL right in position. and the visual outcome also was good. And then, of course, various other designs developed. And by 1980s, with the intraocular lens, people reached a position wherein the visual acuity for distance could be achieved. So the target at that time was that you remove the crystalline cataractous lens and then place an IOL in position. And that was a big thing. And we used to hear in our childhood that, or even in early MBBS days, that, okay, the IOL, was IOL implanted or not? IOL dala ki nahi dala? Agar IOL nahi dala to kya hoga? All sorts of things. And the target of putting the IOL was to have the IOL in position. And then gradually the expectations improved, expectations increased, and then the target became uncorrected visual acuity of 6/6, which was achieved by these lenses. Then the target also changed, that with time what happened that there was posterior capsular opacification, so the retainment of 6/6 was not there. So IOL designs are modified, the optics are modified, materials are modified, and the aim was to maintain the visual acuity of 6/6 in all these patients. So what happened that, with time, people started asking questions कि आँख में lens डला है पर चश्मा लगाना होगा नहीं लगाना होगा, and the ophthalmologist could not say that you don't have to wear glass because the patient had to wear glass for near. So that was the issue. And then people started thinking that can we put a lens which can cater to distance as well as to near, and then came the concept of multifocality, and this was based on the simultaneous vision principle. So two images are formed, one for distance, one for near, and the patient learns to ignore one image, and that is how this principle is simultaneous vision principle, that if the power difference between two optical systems is 3 diopter sphere or more, then the images are dissimilar enough for the brain to interpret them as separate. And that's why they say that it takes a lot of time for the neuroadaptation to happen in order to take care of the multifocality. So the first concept of multifocality came long back in 80s with the New View lens, which was developed by Precision Cosme, which later became Bausch and Lomb. And then it had two focal points, one for distance, one for near. And then some more other lenses also came into practice. Then the first US FDA approved lens was array multifocal lens. And then it had concentric diffractive rings, and it became reasonably popular in 90s, wherein there were alternate rings for different refractive powers. Then different types of lenses came into practice: refractive multifocal lens, diffractive multifocal lens, and then soft optic haptic junction, which is pseudo-accommodative lens. Now, the refractive lens had different refractive powers in different zones, and that is how it was manufactured for different distances, and it was dependent on pupil quite a lot. The diffractive one had a power in the front of the IOL and diffractive, concentric diffractive plates. Now these plates used to split light for distance and for near, and that is how the multifocality worked. And then came this apodized diffractive lens, and that also became quite popular. And then the 1CU acrylic accommodative IOL and the crystal lens also, wherein this optic-optic junction was soft. So whenever there was an accommodative effort, then the lens used to move forward in order to create a refractive system to focus for near. But again, there was a problem that after opacification of the capsule, this flexibility of the IOL does not remain. And so till this time, all these pseudo-accommodative lenses could not come into practice, and the multifocal lenses with diffractive rings, etc., had a lot of halos, glare. They did have good vision. Mostly the diffractive lenses were popular because of the lesser photic phenomenon and better visual outcome. there was a good visual acuity for distance, good visual acuity for near also. In most of these, when we implanted these earlier lenses, the resume and restore lenses, a lot of patients had some degree of satisfaction. But the problem was that when they sat on laptop or computers, they had problems. And other thing was a lot of glare and halos. Now, why this problem emerged more? Because with time, people are more on laptop. And over the last in the last decade or so, the last few years, people have been glued to their monitors, to their laptops, to their iPads and mobiles, and there they require vision for intermediate distance, because when you stretch your arm and see, or when you put your laptop, this OSHA, that is Occupational Safety and Health Administration, it recommends 60 centimeter for comfortable computer work. So anything between 60 to 80 centimeter came into consideration. And then, as we know that there's a saying कि आविष्कार आवश्यकता आविष्कार की जननी है, and people's requirement was for intermediate distance, and that is how came these EDOF lenses, extended depth of focus lenses. The first approved lens was Technis Symphony IOL, wherein they had a diffractive eclipse design. We also have Make in India design of Appasamy, that is suprafob in focus, again a very good quality lens. Then we also had a small aperture EDOF lens in order to have a depth of focus. In all these, what happened that there was not multiple points of focus. There was an extended range, there was a length, and that is how the patients had a better range of vision. So there was correction for distance, and then they had range of vision. So that range extended up to the intermediate, but for near, they required multiple manipulation, like in one eye, people used to implant 0.5 diopter more, and in one eye they used to make emmetropic, and the other eye they used to make slightly myopic, so that they can manage both distance and intermediate. So all these things were being done, and then came into practice was trifocal intraocular lens. And trifocal lens, when it came into practice, then many trifocal lenses have come into use. The earlier ones was AT Lisa lens of Zeiss. I don't have any financial interest. And then the Panoptix lens, which is quite popular. It has 3 foci, one for distance, one for intermediate, one for near. And that is how they get slight range as well as 3 points, so that people can have different range of vision for distance, for intermediate, and for near. And these lenses are quite good. A lot of newer lenses came into practice, and that is how things have evolved. I think evolution is still going on, and I guess the best IOL is yet to come. But in one field, and in multifocal lenses, the patients are still not all patients are very happy. Not all patients are very satisfied. But there's one section of premium IOL wherein patients are very happy and very satisfied, and it is a very forgiving lens, and that is the toric IOL. And the requirement of toric IOL is there because a large number of patients, they do have pre-existing astigmatism. And if there is astigmatism uncorrected, then the clarity of vision is not that great. Even if you can read 6.6, but the clarity of that 6.6 is not there. You do have some ghosting of images because of uncorrected astigmatism. And that is the reason why toric intraocular lens came into practice. The key to success is that you have to mark the axis properly and align the IOL in that axis. And there are various methods of doing it. One is, you can mark it manually, or there are some digital methods as well. So when you are marking manually, the most popular technique of marking is the bubble marker, wherein you ask the patient to stand erect, look straight ahead, see that the head is not tilted, then use the bubble marker to mark the 3 reference points. And during marking, the bubble should be in the center, and that is the key. That shows that the bubble marker is also absolutely parallel to your floor. And then you mark 3 reference points, and then on the table you mark the exact axis. So that is how it is done. There are various ways of doing it. I will skip this video. There are various ways of doing it. People directly mark, ask the patient to look straight ahead and mark the 6 o'clock position, 3 o'clock and 9 o'clock position. You can do it on slit lamp by various ways. So all these things have come up in order to mark. And then once you have marked it, you have to align the IOL in position. So you align, you can see the dots are exactly aligned in position. And there are various ways of doing it. You can do it by Callisto Eye, which is a digital marking system. You don't have to mark it. You just take the picture of the eye, take the clinical photograph, and then transfer it to the microscope. And it's basically connected with the Zeiss microscope with the IOL master. And that is how you can align the IOL in position. You have the very own digital marker system, wherein again, you can align it on the table. It's bang on axis. Then you have the Aura system, that is OptiWave refractive analysis, and there also you can align the axis. And in the post-op period, if you don't get a proper alignment, if the patient does not have clear vision, you can do eye trace, and there you can get the idea how much rotation is required. Because if the IOL has rotated in the post-op period, you need to re-rotate it, and how much axis it needs to be rotated and how much correction it will give, it all is given by eye trace. So many things have come up over time. Since the time of Harold Ridley, things have changed a lot. So IOLs have evolved, but we have to thank people who started it. We have to thank Harold Ridley, who thought of it, that an inert substance, an inert material which is there in the eye can be retained, can be put intentionally in the eye for refractive correction, and it can be retained without any reaction in the eye. We have to thank people like Dr. Ranjan Akhori, who popularized intraocular lens over here in Patna and Bihar. The current generation lenses have come up. They have brought a lot of satisfaction because people are becoming more and more demanding. The age is such, the era is such that people have become more demanding. And we as ophthalmologists have to fulfill their demands by satisfying them, by providing them the best of IOLs. And cataract surgery is the most commonly performed surgery, and that is how we come in contact with most of our patients and most of our population. And what I feel is that in the current scenario, most of these multifocal lenses, they are in a position, like the trifocal lenses, are in a position to provide distance, intermediate, and near vision as well. The only thing is that there are some issues related to eligibility of the eye to multifocal lens. There are some issues of some photic phenomenon. I guess with years to come, we will be in a position to settle all the issues, and I guess with time, we will be in a position to satisfy our patients to the best extent. Apart from putting the IOL, apart from doing our clinical, apart from doing our using our surgical skill, a very important thing is a good patient counseling, and that is what we all keep doing it. So in conclusion, I would like to say that the journey of intraocular lens is still on, because we are yet to replace the crystalline lens in the true form, and that will be, the true form will be that we have removed lens. So maybe a day will come that we can create a small puncture in the capsule and we can inject liquid into the whole bag, which will solidify immediately after putting in. And maybe the volume of the liquid will decide the refractive correction and all that. So maybe that is the future, and we have to, I guess, work a lot in order to achieve that. One more thing I would like to say, that as ophthalmologists, we do handle our patients properly. As ophthalmologists, as AIOS members, we should participate in the activities of AIOS so that we can put our stamp, we can put our mark, we can show to the ophthalmic world that yes, we do exist and we are there to contribute. So that is very important. And till the time I am there, you can always write to me, and whenever, whatever best I can, I will do for you. And of course, you all are stalwarts in your own position, but the only thing is that we have to keep communicating with each other so that we can help each other and we can do whatever best we can. One non-academic slide which I would like to put, for which my apologies, I would like to put my apologies. This is an extremely non-academic slide, but this is a personal request. I'm contesting for the post of General Secretary of AIOS, and I request your help and your support in that. So thank you very much, and I would like to thank you all once again for giving me the opportunity to present this prestigious oration in the name of late Dr. Ranjana Khori. Thank you.
Wonderful talk. Now, may I request our President, Dr. Sudhir Kumar sir, Vice President, Dr. Rajesh Tiwari sir, Dr. Ajay Sinha sir, Secretary, Dr. Gyan Bhaskar sir, and Dr. Ranjana ma'am to come in front. We will felicitate our orator. At the same time, it's our privilege that Dr. Professor Binde Kumar sir, Director cum VC IJIMS Patna, is with us now. So I would request Dr. Vibhuti sir and Nilesh Mohan sir to please bring sir on the dais. And also I would request Dr. U.C. Mathur sir, Director Mahavir Netralaya, to come on the dais, please. Dr. U.C. Mathur sir.
Unofficial but official, we need to support Dr. Professor Rajesh Sinha for his endeavor at AIOC, not by own vote, but by supporting him in all other way, by motivating our friends and fellows at all other places to vote for him. Since he is son of soil and has worked at large for the society, so for his selfless services, we should support him.
Thank you.